Welcome to the Aortic Dissection Awareness Week Patient Symposium. We must thank UT Health in Houston and Dr. Siddharth Prakash and Dr. Diana Milowitz for hosting today's event. Aortic dissection is considered a rare event, but if you look around this room, you'll know it isn't rare to us. I created this foundation in 2003 after my husband, John Ritter, passed away from an acute thoracic aortic dissection. Our mission is to raise awareness of thoracic aortic dissection and aneurysm through research, education, and advocacy. Our goal is to spare other families the unnecessary suffering caused by the unknown.
We wanted to share some highlights of our past 2 decades.
We established the John Ritter Research Program in Aortic and Vascular Diseases led by Dr. Diana Milowitz. Her lab is leading the research investigating the genetic causes of aortic dissection and aneurysm. For the past 10 years, we've funded a patient navigator at the JRRP who recruits families into our genetic research program. And we currently have over 1,100 families participating in the crucial research seeking to identify the specific gene mutations which put their family at risk. We host monthly webinars covering a wide range of topics with global experts in aortic health. And we've recently partnered with the American College of Emergency Physicians, funding a 2-year project to derive the Ritter score, an ER risk stratification tool. We envision a world where every patient who comes to the emergency department with acute chest pain will have a rapid assessment with a Ritter score. This will save lives by increasing the number of accurate acute aortic dissection diagnoses.
We had launched an EMS and pre-hospital medicine campaign to address dissections in the field. We've translated vital information and resources into 5 languages.
We have so much more on the horizon, so keep a lookout.
Oh, and have you made your purple pinky promise to learn more about your aortas? Paint your pinky nail purple, snap a pic, and post on your socials, challenging your friends, too, to make their promise. Oh, and take our 8 simple questions quiz to test your aorta IQ.
Enough from us. Let's turn it over to the amazing experts who are here with you today.
And thank you for knocking on our door. We've been waiting for you. I had to. Is it okay? I had to.
She couldn't help herself. Right, for those who remember. For those who remember, yes, Jack Tripper. So like I said, I'm Meredith O'Neill. I'm the CEO of the John Ritter Foundation for Aortic Health. I'm so excited to be in this room with you. Not only do I lead the John Ritter Foundation with these amazing volunteers and experts, but I'm also an aortic dissection survivor myself. I usually wear it proud. My aortiversary was August 30th. It was 4 years, which is also the birthday of my son. So I had my C-section and my aortic replacement on the same table. So I know what you guys are going through. You can call me anytime. I've spoken to a few of you, and I'm just so grateful to you all for being here. We're going to learn a lot of really great stuff today. So, what is the John Ritter Foundation for Aortic Health? I think that that's something that I get asked a lot. Didn't John die from a heart attack? Didn't he? It was some heart thing. And I make sure to say he passed away from an aortic dissection, a thoracic aortic dissection. And so what is our mission? We did a rebrand this a couple of years ago when I came on board, and we took our mission from a really big mission statement to a small one. And it's to raise awareness of thoracic aortic dissection and aneurysm through research, education, and advocacy. Because our vision is to make aortic health a routine part of the patient and doctor conversation. Because honestly, the reason I get up every single day is to prevent unnecessary suffering because of the unknown. That's a wide purpose, but if you think about it, there's a lot unknown about thoracic aortic dissection and aneurysm that we are going to figure out. And I love this quote from John. He said, "I want to be remembered as just a guy who was interested in the golden thread of humanity that intertwines us all together." So we are all a part of a club that we don't want to be a part of, but here we are, and we've been waiting for you. So how can you get involved? I was talking to Dr. Milowitz about this. And how can we get involved? And this is a picture of the family. We had an event in LA earlier this year, but there are plenty of ways, even locally, that you can get involved. There's a golf tournament in Katy in July called Remembering Benjamin, put on by the Bradford family in memory of their son, who they lost to an aortic dissection at a young age. We have Evening from the Heart LA in New York City. We have Run for Aortic Health, which is a 5K that just happened. Sorry, it's in September, not July. But just happened. Wayne over there, I saw him there last week, which was amazing. So thank you, Wayne. The Adler Paddlers in the Southern California region in March. And then we do the New York City Marathon as Team Ritter. And we also have the LA 5K this year as a new active event. Now, if you've had a dissection or at risk, we don't suggest that you do a marathon. Get a friend or family to do so. My friend is my legs in the marathon. But why do I bring all these things up? First of all, we want you there. You know, you guys are the reason we do all of this. It's not only for you, but for your children, your sisters, your brothers, your siblings, your parents. But do you want to host one? We'll always be here to help you. We just had a woman that did a bake sale at her work, and it raised over $2,500 this week, just from a bake sale, in honor of her husband who survived. So if you ever want to host one, we're here. That's to you, of those of you online as well watching. We would love to have you host something. And then science and education. You know, the more information that we have, especially genetic material, and the more people we have involved, first of all, our megaphone gets bigger, and you'll hear from Dr. Milowitz that the research, we need it for research. So what are some of the ways that you can do that? The John Ritter Research Program is one way. You can find all of this on our website. You'll be hearing a lot about that later. We have Final Friday webinars. So a lot of our esteemed colleagues sitting over here have been the hosts, the experts on these. And we cover subjects from exercise to mental health to genetic testing. And it's a really great way. You can find all of those online on our website. Mended Hearts is a program that we just started partnering with, and we are doing a specific program. So you'll be seeing some things coming out about it. And it's getting people trained to go in and talk to people after they've had an aortic event. Because as we all know, you feel a little lonely after you have a dissection. So we want to make sure that people know they're not alone. The Aortic Dissection Collaborative is now powered by the John Ritter by the John Ritter Foundation for Aortic Health. There is something online, and this is a group of shareholders that are helping guide the research priorities within our field. And then I have 3 really exciting things that you're going to be seeing coming up. You're the first to hear it. The Aorta Academy is going to be an online web resource that has all of the educational materials that you could ever want. Well, maybe not ever want, but all the educational materials that we have in ways that you can learn and be a responsible advocate for yourself. And speaking of advocates, we will be launching at the end of this month, at the end of October, you'll be seeing Aorta Advocates, and this is going to be a group of 20 people who are going to apply, and we're going to be putting them through an in-person training in Colorado for 2 days, an intense training, so that they can help people navigate their aorta journeys. It's not a support group. Instead, it's more of like a guide. It's somebody who can help people find the resources they need and the support groups and things like that. So they're going to basically be unpaid employees. So exciting. And then Faces of Thoracic Aortic Disease. We are going to be starting a speakers bureau. Your stories are the reason why we all get up. It's the purpose that we were talking about. So we will be putting together a speakers bureau in case somebody comes to us needing a speaker for one of their events. So the last thing I wanted to tell you before they start playing the music to shoo me off the stage, you got this wonderful brochure when you came in. I made it myself, so tell me how great it is. Yes. And to those of you online, you can request these, especially if you're at a hospital or know a hospital that needs it. This is just a quick, simple way for you to see what we are doing and words that you can tell friends and family. And it has everything in it that you need with QR codes, specifically around imaging, genetics. And like I keep saying, we have everything on our website, which was curated by our Chief Science Officer, Ellen Hostetler. And on the back, it has some of those resources that I was telling you about with Get Involved. And then another thing that you got was the Ritter Rules. We have them in English and in Spanish. We have a lot of copies of these, so please take some to take to work. These are, or to your church or wherever, but these are the signs that Dr. Millowitz helped curate and based on the 2010 guidelines. So these are very, very important. And then also be really cool and wear your John Ritter Foundation sunglasses because I'll give them to you, Diana, and I have a few. Don't worry. I would never leave you out, Diana. But overall, I just wanted to say thank you, welcome. We really are glad you're here. And I am so excited to hear about all of the things that Dr. Prakash has ready for today. All right, thank you.
Good morning, everybody, and thanks for showing up and learning more about aortic health. I really am excited about what the JRF is starting to fund to really understand this disease and better care to prevent aortic dissections and also better care for people that have suffered an aortic dissection. So they are funding the diagnosis of an aortic dissection in an ER, as Meredith already talked about. They are funding the John Ritter Research Program, which I lead here, and I was very fortunate that the John Ritter family lended their name to our research program. In this research program, we're trying to identify all the genetic triggers for aortic dissection. And the idea is to have that information ready when we go to whole genome sequencing as part of our medical care so that we can go through the population and pick out who's at risk for a dissection. And I think we're probably about 5 to 10 years away from whole genome sequencing being done as part of our medical care. So we really need to ramp up these studies and be ready to go. And the John Ritter Foundation also just recently funded 2 additional grants. One is to look at exercise post-dissection and to make sure that the recommendations we make don't harm people after dissection, but also to really make sure that you do get some exercise and you know that you're doing something that's safe. And actually, Dr. Prakash is leading that study. And the second study is to look at mental health after dissection. We've had many patients that have symptoms of post-traumatic stress after dissections, and so that issue definitely needs to be better addressed. And these came out of that aortic dissection collaborative in which was led by Dr. Shireen Shalou. And many of us were involved in it, but we went to the patients and said, the dissection patients, and said, what is not working in terms of your care and your management and your understanding of the disease. And so we have a list of initiatives that come from patients with aortic dissections. And so genetics was up there, diagnosis in the ER, but also mental health and exercise. So we're trying to address these issues through the through research grant awards. And so please consider getting involved in the John Ritter Foundation. And then I want to thank the people that organized this symposium this morning. I asked Dr. Prakash to take the lead, and he's done a wonderful job with the help of Elena Checky. You want to raise your hand, Elena? And Isabella Marin over here, and Jennifer Thomas, and who am I forgetting? Mara. And so they're outside, so please thank them when you see them because they spent a lot of time and effort getting this organized. So I'm going to give you a very short talk about the genetics of this disease, and I'm going to start out by talking about why we're going after the genes. And this is really, very simple. Here's the illustration of thoracic aortic disease. There's a normal aorta here, an aneurysm that forms here. And these aneurysms tend to be totally asymptomatic. People don't know they have them. So unless somebody is known to carry a risk factor and gets imaged or gets imaged for another reason, they typically go undiagnosed. And with an aneurysm, we can follow that aneurysm, put people on medications that will slow the growth of the aneurysm. But ultimately, the treatment is what Dr. Estrella does, going in and actually fixing the aorta. And when we do that so we prevent those acute aortic dissections, those ascending aortic dissections. And we want to prevent those because our current data says that 50% of the people that have a dissection never make it to the hospital. And those that do, there's another 20% that die during the emergency surgery. Yet a lot of you are nodding your head because you know how touch and go it can be. So and this is a disease we can prevent in essentially everyone. And so we want to know who's at risk for this disease so we can follow them, diagnose those aneurysms, and repair them so the dissections do not occur. So one way to do that is to look at the genetics. And so that's been my approach for over 20 years, to find the genes that predispose to the disease. And what we're looking at in terms of the genetics is that at one end of the spectrum is you have people that have a syndrome. That means that they have a high risk for thoracic aortic aneurysms and dissections, but they have other involvement of other parts of their body. And in the case of Marfan syndrome, they grow very tall and have very long fingers. Not all Marfan patients grow tall, but most of them do. And then there's other, so we know these syndromes are due to alterations of a single gene in the human genome. And we've defined most of the genes that cause this syndromic presentation. But we also have families like John Ritter's family, where they don't have any external manifestations that would allow them to be picked out of the crowd as being at risk for a dissection. But they have multiple members in their family that have had dissections. In the case of John's family, he had his dissection in his mid-50s. His father died in his early 60s after grabbing his chest and dropping, and most likely died of an aortic dissection. After John's death, we imaged other members in the family, and John's brother was found to have an aneurysm, went to surgical repair, and still is alive 20 years later. So that's how we can use, whether we have the gene or not, we can use the information that runs in families to help prevent further dissections in families. And then at this end of so this is about 20% of the disease. 1 in 5 people with a dissection will have a family history or one of these inherited syndromes. And in the case of families like this, we expect it to be similar to those Marfan patients, that there's an alteration in just one gene in the human genome that's conferring such a high risk for dissection that multiple people in the family are dissecting. But at the other end, the vast majority of people with dissections, that's illustrated here by Richard Holbrooke, who was the Undersecretary of State to Hillary Clinton and actually dissected in her office and died a few days later after surgical repair. And this is Michael DeBakey, who ironically had his dissection when he was 94. And I say ironically because he pioneered the surgical repair of an aortic dissection here in Houston. The first successful repair of a dissection was done here in Houston in 1956. You're at a great place to get your aorta repair because there's a long history of great surgeons like Dr. Estrella here. So we need to, we've been working many years to find all of these genes, and so we've got most of the syndromic solved. In terms of the familial, we only solve about 35 to 40% of the families. So we still have more genes to find for our families in our study, and we're up to over 1,300 people in our study, 1,300 families in our study, and that translates to thousands of people. But we have to do better on this end of the spectrum, because I think somebody like Richard Holbrooke had some genetic variants that predisposed him to the disease, but these weren't strong enough to cause dissection in everybody in the family. And he had to have a second hit, either hypertension, which we know is a big risk factor, or another genetic variant to trigger that dissection. So we're going after, in these people, the genes, but also those environmental triggers. And I don't think I think there's still more environmental triggers that we don't know about. And I think that because there's data to say dissections are actually increasing in many countries around the world. Good data out of some of the European countries, the dissection rates are increasing. So that would suggest there's something in the environment. Okay, so if you're in one of these families, like John's family, this is a pedigree that illustrates how the disease would be inherited in the family. Men are squares and women are circles, and a line between them means that people are married. The line down goes to their children and the next generation and the next generation. And everybody in black is affected. So you can see it does get passed down from one generation to the next, but here is somebody that didn't pass it on to all of his children. So if somebody has this predisposition that's running in the family, it's a 50-50 chance that they're going to pass it on to their children. And there's nothing to do in terms of altering that risk short of in vitro fertilization with selection of embryos that don't carry the variant. There's no way to predict one way or the other whether or not a child will inherit the predisposition. But using these families, we've gone on to identify a whole list of genes. And as I said, this explains about 35 to 40% of the families in our studies. So we're doing pretty well, but we're not there yet. But we can use this information to start screening families that look like this. And once we find the mutant gene, that information becomes very powerful because that allows us to go through the entire family and say, you have the alteration, you do not. We have to image you, we have to follow you up carefully, but the other sibling without the alteration, we don't have to do that. And then it also tells us when to do the surgical repair. It tells us whether we have to worry about you going on to have aneurysms elsewhere in your body, like in your brain. It even tells us whether you're going to go on to have problems with early onset coronary artery disease. So there's a lot of information once we find that gene that becomes very powerful for your family and for yourself. So with that, and we hope to have an answer for all the families in the next few years. So all these genes are on diagnostic panels that worldwide and can be tested in people. And I'm not going to talk about the results and how you use them, but just in the last few minutes just focus in how do we use genetics to identify individuals at risk for aortic dissections. So number one, if somebody in the family or yourself has had a dissection, like I said, 1 in 5 will have a family history. And sometimes that's a clear dissection. Sometimes it's that somebody died suddenly and they thought it was coronary artery disease and an autopsy was never done. And that was the case with John's father, who was actually Tex Ritter. Some of you may have remembered Tex Ritter. And but even without a history of that, we can pick up family members that are affected. Because like I said, those aneurysms are completely asymptomatic. So the current guidelines say that if you have an aneurysm or dissection, that all your first degree relatives should be imaged. That means your parents, your siblings, and your children, okay? And the following patients we're recommending genetic counseling and testing. So that's people that have those syndromic conditions like Marfan syndrome. If you have other more than one family member with the disease, we recommend you get counseling and genetic testing. And then anybody who's had a dissection under the age of 60. We know if we sequence people under the age of 60 that present with a dissection, that 10% of them will have an alteration in one of these genes. And that, once again, either came from one of their parents, but it will definitely, possibly be passed on to the next generation. And we want to get ahead of this disease because that's the only way we can prevent these dissections. And then finally, for people that don't get referred for genetic counseling and testing, we do recommend the imaging of all first-degree relatives. So I thank you, and I'm going to turn it over to the next speaker.
Good morning, everybody. My name is Justin Wigan. I'm a pediatric cardiologist over at Texas Children's. And I'm actually going to start with my poll questions as well. Remember my training from earlier this morning. I will start with this one, okay? Launch, okay. So hopefully in the next 10 minutes or so, we'll answer this and the next poll question for y'all. And I think these will be very much echo Dr. Milowitz's comments about empowering patients even beginning in childhood. So this is the first question. 12-year-old boy recently diagnosed with Marfan syndrome. Your cardiologist tells you he has an aortic aneurysm. When your child asks you about exercise and sports, which of the following is appropriate? And so this one says, if you're a launch it, yeah. If you're an 18-year-old woman with Loeys Dietz experiences sudden severe chest pain, weakness, and a racing heart. Her mom brings her to the ER. Which of the following is not appropriate to rule out an aortic dissection? All right. I think you guys are onto something. All right, I'm going to start chatting, and hopefully these will become a little bit more clear over the next couple minutes. Okay, so as I mentioned, I'm a pediatric cardiologist, and I think to extend on what Dr. Milowitz was saying earlier on, I think part of our job in pediatric aortopathy disease is to empower patients and families. And so that's what I'm going to kind of focus on and let's advance. Let's get on a click here. Okay. All right. So this may seem a bit elementary here, but I just wanted to define what we're all talking about because this is what I do with our patients, our children, and our families. An aortopathy is a often genetically mediated condition associated with aortic dilation, plus or minus syndromic features, in which dissection or rupture is a potential complication. And it's really important to make this diagnosis because, as Dr. Milowitz alluded to, prophylactic treatment can be life-saving. And that involves serially monitoring the aorta with imaging, medical therapy to reduce the rate of aortic growth, and prophylactic aortic root replacement. And this is just a picture of a dissection, which I'm sure many of you in this room have seen, really referring to the tear in the innermost layer of the aortic wall, allowing blood to enter between that and other layers of the wall. And this is more, this happens more in vulnerable aortas, and that's what we're all working on and all concerned about, is that patients either with syndromic or non-syndromic aortopathy have vulnerable aortas for this to happen. And this can occur both in this ascending part of the aorta, but also later down the aorta. And those are surgically termed different types of dissections, but the idea remains the same. So very briefly, how do we approach our pediatric patients with suspected either syndromic or non-syndromic familial aortopathy? Really, this lies at the intersection of a good patient and family history, our exam, meeting the patient, echocardiography, and genetic testing. Really, this is where making this diagnosis lies. And so the patient and family history is really geared towards clues to other organ systems involved that may clue us into either one or the other genetically mediated aortopathies. And it also, I tell patients, the family history is as important as anything. As we heard about the Ritter family, knowing what happens with the family history is as important as anything we do on our first evaluation, looking for red flags such as aneurysms or dissections, looking for other organ involvement like hollow organ issues, and really trying to see if there's anything within the family history that can clue us in as to why we're seeing some of the dilation that we're seeing in the aorta. A staple of our evaluation, and I'm not sure if this will play, it doesn't look like it will play, but this was a This is an echocardiogram, and this is really a staple of our evaluation, is serial and surveillance echocardiograms. And here we see a picture of the aortic root that's dilated. So all our patients who are coming in for their initial evaluation will get an echo. And you can see this, a little bit of a complicated slide here, but what we're doing is we're trying to find out what particular features either a patient has or, importantly, does not have that makes us think about syndromic or non-syndromic, more smooth muscle-related aortic diseases. And this is just us trying to think about what is common to many of these and what can really distinguish between them. And then, as Dr. Milowitz describes, genetic testing has become a huge tool for us to use in identifying patients and families at risk. And that is for both the syndromic aortopathies and those patients in whom we see dilation of the aorta on our screening echo, but really don't have any kind of suggestive physical exam findings or features. So I'm going to focus on just a few of the genetically mediated aortopathies for the sake of time, just to highlight a few key differences. And these are some of the syndromic ones that we see. But I think our approach is very similar in the sense that we're trying to counsel patients in an effort to empower them. Knowledge is power, especially when we're dealing with children in whom, fortunately, the risk of a dissection is relatively rare. So a few of these that we see commonly are Loeys-Dietz syndrome, which has a bit of a more insidious vascular prognosis. These patients tend to have more arterial involvement just beyond the aorta, like aneurysms of the head or neck vessels. They tend to have very tortuous aortas, and they tend to dissect, importantly, as it pertains to our discussions today about dissection, at earlier dimensions or at smaller dimensions. For Marfan syndrome, this is more likely, as you can see, to be passed through families, meaning it tends to be less new in the family, and that's why the family history is so critical, even with some of the syndromic diseases. And they present similarly with root aneurysms that I showed on that echo slide just on that last slide. What's important about us as pediatric cardiologists is to acknowledge that pediatric patients may not look very syndromic, even when they have such diseases, because this is a disease in evolution. Oftentimes, patients do not show or exhibit many of the physical exam features until later in life, and we're meeting these children very young sometimes. So it's important to keep following these patients and families if, in fact, we see that there's aortic dilation present. And then vascular EDS, this is a aortopathy that has a significant risk of aortic dissection, predominantly in the patients who have this particular COL3A1 mutation, and they can actually have other areas, other arteries involved. And so this is a very important thing for us to think about when we hear about patients who have arteries in their shoulders, in their neck, in their head involved. And they can also have their veins involved as well, and they can have enlargement of those that can lead to hematomas. So we're here and we're all trying to prevent dissection. And knowledge, even in the pediatric age group, is important. And we know that Loeys-Dietz in particular has a very high risk of dissection. Marfan syndrome has roughly a 250-fold increased risk of dissection, as does vascular Ehlers-Danlos, which has a very high risk of rupture. And what we do in terms of our medication, even in our pediatric populations, is we tend to start them when these and other familial or non-syndromic aortic diseases are identified to reduce the rate of growth in our aorta. And then we have, I won't belabor this too much, but we do have surgical thresholds that we discuss with our families, even at the time of diagnosis, so that families are empowered to know at what point we may need to visit that particular prophylactic surgery. This is a very challenging part of our job. We talk about ways to reduce the risk of dissection even in the pediatric years. And one of the ways to reduce the risk of dissection in even our peds patients is to really reduce the hemodynamic impact on the dilated and susceptible aorta by making lifestyle changes. And some of those particularly challenging ones in pediatric patients is activity restrictions. If you go strictly by guidelines, our patients are recommended to only take part in activities that are seen in this kind of bottom lower left-hand corner as outlined. And we try to really balance the perceived risk in each patient with the mental health of these patients. So unfortunately, we're challenged with a lot of pediatric patients who are already well entrenched and have developed a passion for certain sports. and then we come to find that they have a dilated aortic root. And this is a really challenging thing for families and our teenagers especially to deal with. And so, you know, especially if their aortic dimensions are mildly dilated or normal or close to normal, we kind of take a case-by-case approach to help counsel families about what might be safe for them and what might have to be pursued with assuming a little bit of risk. We don't really have any formal restrictions at early or elementary school ages. We let kids be kids. It's hard to do that with toddlers and young kids to kind of restrict them. But starting around 8th grade, we start to impose activity restrictions. And namely, those are staying away from contact or collision sports, heavy weightlifting or isometric activities, those which rapidly increase your blood pressure and impose attacks on the aorta. And we encourage families to steer young children towards activities they might be able to pursue through the course of their lifetime, so that, you know, getting to a point where we'd have to pull them out of something for which they've developed a passion is less likely to happen. In general, low-intensity aerobic activities are to meet the needs of each particular patient is encouraged. Being a couch potato is bad. And you know, we've started to realize this both in the lab and in reality in clinical practice. So there's a study that found that moderate dynamic exercise actually in mice who had aortic root dilation was good for them. It decreased the rate at which their aorta dilated. But if you were sedentary, if you were a couch potato mouse, you actually had faster rates of aortic dilation. And as described by Dr. Milowitz, both on the adult side and on the pediatric side, we're working now to find and prove that exercise is safe for patients so that we don't incur other risks, such as things like obesity and hypertension that is not good for your aorta either. I'll spend a few minutes on this because this is something that we, or just a minute on this, because it is something that we encounter and counsel on in our young female population. We counsel our female patients of childbearing age that pregnancy does increase the risk of aortic dissection. In Marfan syndrome, for example, the risk of dissection in pregnancy is associated with an increased rate of your aorta growing. And so surveillance and knowledge of having this disease when you're planning for pregnancy is important. For instance, patients with Marfan syndrome or similar syndromic aortopathies and even familial aortopathies, we recommend at least trimester echocardiograms to ensure that the aorta is not getting significantly dilated at each trimester. And even after, even in the postpartum period where we know that there's an increased rate of dissection. I really put some of the examples here of what we talk about with our female patients, that all patients should be followed by high-risk MFM. And as I mentioned, the risk of dissection seems to be higher in the third trimester and postpartum period. And it's important to know what medications you can safely be on during pregnancy. So these are just a few of the counseling things that we have aimed at really reducing the risk of dissection in our females of childbearing age. One quick thing just to know that came out in 2018 that we put at the end of every note for our patients who first come see us is that there have been, based on kind of adverse event reporting and some observational studies that have been published, it appears that fluoroquinoline antibiotics are associated with increased risk of aneurysm and dissection in patients who are prone to this. I think this, if you have to remember one slide that I talk about, this is the slide to remember. Because I mentioned really it's about knowledge, empowering patients because knowledge is power, especially in the pediatric age, and getting patients to understand their disease process even as teenagers. So as I mentioned, arterial dissections are pretty rare in childhood, but it's important to start counseling about emergency plans from the initial diagnosis. We ask our teenage patients that they should be able to give the name of their diagnosis. They should describe what it is that their diagnosis affects, so be able to describe the aortic disease, and they should know what medications they're on and the doses, and verbalize what they need if they come in with chest pain. So what does an aortic dissection feel like? This is something we talk about with them. We talk about sudden severe chest pain that goes to the neck or goes to the back. We talk about other sensations that patients have described, such as a tearing or ripping sensation. And we talk about other symptoms that they might feel, such as feeling lightheaded from a low blood pressure, rapid or weak pulse, short of breath, and then changes in their vision or difficulty speaking. And then we say to patients, teenagers, and families that they should call 911 and seek immediate evaluation in ER for rapid imaging. And this goes to one of the poll questions about what suffices when you present to the emergency room, especially if it's not in Houston or it's not in big centers where caregivers may be less familiar with these diagnoses. And I highlighted the answer to that question here. And this is actually on the Marfan syndrome or the Marfan Foundation website. They have a similar card for many of the syndromic aortopathies, but the idea remains the same. We give these to our patients at the time of diagnosis, and we ask them to carry it, both they and their parents in their wallet, especially as they're going off to college and things like that. The most definitive tests for diagnosis of aortic dissection in the emergency room are a CT scan, an MRI, or a special kind of echo, a transesophageal echocardiogram. A chest x-ray will not diagnose this and should not be the only thing that patients get when they come in the emergency room. Similarly, if a patient has a thoracic echocardiogram, an ultrasound in the chest, we would encourage that the patients and families ensure that they're getting next level kind of imaging to ensure they don't have a dissection. So I'll finish up with my take-home points here. So features of syndromic aortopathies are often subtle in the pediatric population and absent, I should say, in terms of patients who have non-syndromic aortopathies. And these things may evolve throughout childhood. So this really underscores the importance of making a genetic diagnosis. This will help us to guide thresholds for potentially life-saving prophylactic surgery. We employ medical therapy, and we do that to reduce the rate of dilation. We do not yet know what its overall risk of mortality and morbidity are, but we think by slowing the rate at which the aorta grows, we are mitigating risk of dissection. We talk about surgical interventions. They're aortopathy specific, and they're nuanced by other things that are going on in our surveillance of these patients. Proper surveillance and lifestyle modification can help mitigate the risk of dissection. That's the one big thing we talk about with a lot of our pediatric patients, especially teenagers. And knowledge is power. Knowledge about your condition can be life-saving for you and empower the emergency medical providers wherever you may go. So I think that's all I have.
Okay. Good morning, everybody. I'm Bella, and I'm a nurse who works with Dr. Melowitz and Dr. Prakash, both in clinic and with the John Ritter Research Program. I'm going to start my talk with some polls, just like we've been doing. I wanted to bring up Dr. Melowitz's poll because I'm going to address it a little bit in my talk. So this was the true or false of genetic testing is more expensive than an echocardiogram or ultrasound of the heart. So the correct answer is false. Genetic testing is more convenient and accessible for patients to pay for than an echocardiogram. So as far as the cost for either or, genetic testing is cheaper than an echocardiogram. And so this first one is, how important is knowing your family history in your healthcare? So on a scale of 1 to 5, 5 being the most important and 1 being least important. Is that a 5? How many of your family members have ever been diagnosed with a thoracic aortic aneurysm or an aortic dissection? So this is an aneurysm or dissection occurring in the chest part of the aorta closest to the heart. And then I have 1 more. Actually, I have 2 more. I went over the top with me. Do you feel comfortable to ask your relatives about their medical history? Okay. And this last one is, if you or anybody else in your family has had genetic testing for an aortic aneurysm or dissection, what was the result? So was it a positive result? You have an identified gene in your family that increases the risk for this. Negative, meaning that you've had testing, there was not a gene identified. Inconclusive, genetic testing was done, but there was a variant of uncertain significance. And then no one in the family has had genetic testing. Okay, so I'm going to talk about family history, and if you got from the polls how important it is when it comes to thoracic aortic aneurysm and dissection. So a discussion, that's really recommended to have with your family members. I'm going to start out by sharing a case that I have worked with in the research study. So again, like Dr. Mulowitz said, this is a pedigree, so it's the family tree of the person. The blue arrow indicates that they are the proband, so she's the first person in the family to be affected by this. The black shade means that she's affected by thoracic aortic aneurysm or dissection. Squares are men, and the circles are women. So here we have a woman who at 55 years old presented with a type A dissection suddenly. She had no family history, so you can see that all of the other shapes in this pedigree are blank. So she had no known family history. She was healthy all her life. She was actually routinely running marathons. So this was a surprise for her when she presented with the dissection. And she had the repair, and she was told to tell her family members to get screened. And so like we've talked about, the American Heart Association recommends all first-degree relatives of somebody who's had a thoracic aortic aneurysm or dissection to get screened. And this is with negative genetic testing. So if there's not a gene found, then these family members are all considered at risk and should get screened to make sure there's nothing there, because an aneurysm can be present without any symptoms. And so she had negative genetic testing, and she said that she posted in her family's Facebook group what happened to her, and she's relayed the recommendations, and her family members went to get screened. So it turns out that her 91-year-old mother was screened, and she was found to have a thoracic aortic aneurysm. So again, no symptoms. She did not know that it was there, only because she was getting screened because of her daughter's dissection. And so the rest of her siblings got screened, and her brother ended up having a thoracic aortic aneurysm that he was being followed for, and he ended up dissecting. So they were just keeping an eye on it, and it actually dissected before they could go into the repair, which is not something that usually happens. They usually, are able to keep a great watchful eye on it and watch the growth in time. But this family in particular happened to be dissecting at smaller diameters. So this is when Dr. Wagon was talking about family history is important in the clinical care as well. So recommendations will be made based on your, what happened to your family member when they had their dissection or their aneurysm. And so this family, it's clearly genetic. We have 3 family members that are affected, negative genetic testing. So it doesn't mean that it's not genetic, but it could be a gene that hasn't been identified, which is where our research program comes in, that's led by Dr. Milowitz. And so she has discovered some of the genes that are on the current testing panels, and we're working on finding more. But this just goes to show that, we don't have a gene for this family, so all of the family members can get tested, and everybody can see, who's not at risk, who's at risk, and who needs to be followed. So in this case, all the siblings and now the children of the 2 people who had the dissection are going to need to be screened. This is because the genes that cause thoracic aortic aneurysm and dissection, they're predominantly inherited in an autosomal dominant manner. So what this means is that there's a 50% chance if you carry the disease or, the gene in question, even if we don't know the specific gene, you have a 50% chance of passing it on to your children. And that's why these screening recommendations go down to the children after the generation of the 2 who dissected. So if you just kind of brief genetics, we inherit 1 set of each gene from each parent. So we have 1 from mom and 1 from dad. And autosomal dominant means that we only have 1 altered copy. And so, for example, the 3 family members here, they have an altered copy of some gene that is increasing their risk for dissection. And so they have a normal copy of the other gene that they got presumably from dad. And so they have a 50% chance of passing that altered copy on to their children or their normal copy. So for the woman who first dissected, her 3 boys, they have a 50-50 chance of inheriting either the altered copy that has the higher risk for dissection or the normal copy that's a general population risk for dissection. So this one was, the story has stuck with me just because, she could have been considered a sporadic case at first, no family history. This could have started with her, but if it weren't for those screening recommendations, now we know that this is something running in her family, and her family members can, take it more serious and get their screening done. So even if somebody seems to be the only one affected, this is why we recommend that those first-degree relatives get screened for this. another family that I wanted to share. They have also had negative genetic testing. So the one with the arrow again is the proband, or the first person affected in the family. So he actually presented with a thoracic aortic dissection. Wasn't really, he's in contact with his family, but they don't talk about their medical care or their health history. And so after he dissected, he talked with his father, with his parents about his history and saying, hey, you should probably get screened. And the dad came back and said that he had an aortic root aneurysm, which is a thoracic aortic aneurysm, so close to the heart. So ideally, when the dad was diagnosed with the root aneurysm, we should have had his brother, his 2 children get screened. So maybe the person who had the dissection could have had it repaired electively if he knew that there was an aneurysm there at the time. Just he had that little discussion with his dad, which it can make a difference between life or death if you're talking about your family history in this area. And you don't have to disclose a lot of detail with your family members. You can always at least just, send a link, American Heart Association guidelines, and you don't have to say too much. But this is something that is, life-saving in some cases. But we also found out that his paternal grandfather, so his dad's dad, had an abdominal aneurysm. And so those, they're common in the general population. If it's somebody that's over 70, it's a male, smoking history, it's a male, he's a male. And it may not be seen as genetic. So maybe the dad who had the aortic root aneurysm and his dad who had the abdominal aneurysm, there was not a link linking them together to say that maybe there's something genetic in the family. So again, this is just illustrating how it's being passed down in every generation. It's clearly genetic, there's not a gene, and how the difference between the 2 family cases here of just having that little conversation with your family members about this risk. So this is just the last thing that I wanted to share. This is a screenshot from the Ambry genetic report. So if any of you have had genetic testing from Ambry, you might have seen it in your report, but this is illustrating the first degree relative screening. So putting it in a visual for you all. So the person that's shaded in blue, she's the one that has a thoracic aortic aneurysm and dissection. And the ones who are in gray are recommended to talk to their doctor about being screened for this. So again, this goes to the parents, the siblings, and the children of somebody who's had it. And the takeaway from my talk is I really want to illustrate the importance of the family history and talking to your relatives, and like we were saying, the knowing what happened to your family member could also be used in the monitoring and care plan for yourself. So they can make recommendations based on what happened to your family member, and whether or not there's a known gene. That's something that will still be helpful and impactful in your care, and it's meaningful. So I always feel odd talking about family history and asking my patients about it because I don't know that much about my family history. So this just, it's a very easy discussion to have, and you really don't know until you ask, because a lot of people don't just go up and say, hey, I had an aneurysm, unless you're Meredith had a dissection. So yes, that is the end of my presentation. Thank you.
I'll introduce myself first. My name is Greg Weaver, and I am a board member on the John Ritter Foundation, and I'm probably the guinea pig in the room. That I'm going to go through my whole family history, and that's aortic aneurysms with family members passing away, family members getting their aortas replaced, young family members who have the gene, they discovered the gene. I think at the end of the day, it's all great news, and it's great that you're all here. The research that's being done here has changed our family. And this mystery that with our family dates back to the 50s is solved. And it's because of what's being done here. And it takes you now, being a survivor, being a family member, being someone who's just interested in it, going out and having your family tested, being watched, sending your DNA in, get into the testing program. And Dr. Milowitz said it. I'm not a doctor. I'm not even close to a doctor. But I say this sometimes, and I'm glad she said it too. Nobody really should pass away of this anymore. There's probably anomalies, but nobody should pass away if people do the homework and do the research and get into the program. And that's what we've learned with our family. So I'm going to go through the history, but I think I'm supposed to do a poll quickly here. Is it on it? So I just click the play button here. Fine. Now I need to get my glass out to read the screen here. Are you currently participating in a research study about the thoracic aortic aneurysms or aortic dissections? And as the answers are coming in, this is what our family did. And we did it in 2005, and I'll tell the history here in a moment. And, you know, for our family it was important, but just for science, for everybody else, for all, you know, everyone who's inflicted by it, we took that step. And luckily we were told about it by a cardiologist in California who was working, Dr. David Lang, who was working with Dr. Milowitz on this research program. And so we were the lucky ones that we had the right cardiologist at the right time who told us about the program, and we got into it. So it's been amazing. So I'm going to stop the poll there. I'm going to have you, I don't have any slides. I am the slide. I do think I should make one of the family trees for our family as we've done that, to put pictures, because we have lots of different, yeah, well, I'll add pictures and some stories to it. So again, my name is Greg Weaver. I live in Austin, Texas. I make myself available to any of you, whether it's here today, offline, or whatever else, you know, to learn more from our story. So I'll start high level, or just the history. And it's interesting seeing these different families, you know, that are, you know, real families, but without the names on it. But our family could have been a couple of those up there that had like 3 or 4 different people. So it started with my grandfather in the 50s, who I never met. He passed away of a sudden heart issue, and they didn't do an autopsy. And so no one knew at that time. It was kind of heart attack. And that was it. But as you hear the rest of the history, most likely it was probably of an aortic aneurysm. Then in the 60s, it was about, I think it was like 1962, 63, my uncle, who I never met, passed away suddenly at the age of 26 of aortic aneurysm. Now, the good news is they did an autopsy, which was rare, I guess, in the 60s, you know, when it was kind of a heart attack. But they did an autopsy, and we were able to get the autopsy results from the county hospital that he passed away in, which was, again, kind of rare for us to be able to get that. And then in 1983, my father, at the age of 42, passed away suddenly. Again, at the moment, it was a heart attack. I was 13 years old. They thought it was a heart attack, but they immediately did an autopsy, and it was an aortic aneurysm. And when you compare, and this is kind of the web and the research of getting all this family history and bringing it all together, when you put the autopsy reports side by side, you know, there's a lot of description, a lot of the, you know, the medical description of it, but they do a very simple exhibit, and they show the aorta, and they show where the dissection happened from where the valve is in the aorta. It was the exact location, and it was handwritten in the 60s with my uncle, but it was much more in the 80s. It probably wasn't that much better, but it was a better image. But they measure it from where the valve is, was the exact same location. So in 1983, that's when like the alarms went off. It was like, it's not a coincidence. This is, you know, there's something more here. And so our family immediately we went to Stanford Medical Center, and we're tall, skinny. I'm not so skinny anymore. I was a lot skinnier back then. But immediately they tagged us as Marfan's, because we had a lot of the physical attributes of Marfan's. So we went through the Stanford Medical Center Marfan clinic, and we didn't have Marfan's. So then all of a sudden, there's the new mystery, and all the research that's done today. Again, this was in 1983. There wasn't a lot known, but clearly there was too many coincidences that there was an issue. And so immediately our family just started getting tested. It was once a year we'd get an echogram. And for those of you that have had an echogram, it's simple, it's easy, it's non-invasive, it takes 15, 20 minutes. And so our family just every year started getting an echogram. And I did it myself all the way, I'm probably every year since I was 13 years old, I've had an echogram. My brother, who he may be watching, he in his 20s and maybe in his early 30s was super healthy, was single, didn't have kids, was kind of living the dream, like having a great time, might have thought he was invincible. And he quit getting his annual echogram. And 2005, wakes up in the middle of the night, has some of the symptoms. It was right in the chest and the back. And he was living by himself in Seattle, Washington. And he's like, huh. So he calls 911 and he lived at the end of this little cul-de-sac. And he's trying to convince the 911 operator, hey, I'm having this issue. And thank God the 911 operator started asking all the right questions. Do you have family history? Do you have this? Do you have that? And he's like, yeah, my father, my uncle, tells a little bit of the history. And then my brother's like, and they're like, hey, we need to send the EMT and the ambulance out to you. And he's like, that's fine. He's like, first he tried to talk, he's a lawyer, he's a litigator, and he's trying to convince the EMT operator that he's gonna drive himself in and, or the 911 operator. The lady's like, nope, you're staying put, we'll send somebody. And now he's saying, okay, send them, but have them not put their lights on and their sirens, because it's like 2 a.m. And the lady's like, she's just talking over him now, like, okay, and keeping him on the phone, keeping him talking. And then my brother hangs up with her and says, I'm walking to the end of my street so I can just meet the ambulance so they don't meet the neighbors. Well, they heard all the family history. They sent the brigade. It was like fire truck, ambulance, the whole deal. He didn't get halfway down his little road, and everybody was there. And the good news about that whole thing, it saved his life. They got him to the ER, told all the history. They did an echogram. He had an enlarged aorta. It wasn't abnormally at large for a typical person, but with the history, they're like, you know what, this is, we need to dig deeper. The next day they dug deeper. And within a couple days, he was at Stanford Medical Center and had his aorta replaced. And when they came out, he's alive, by the way. He's healthy as can be. They said his aorta was paper thin. He was a ticking time bomb. And he was running, like I'd said before, he was healthy, running marathon. He ran a marathon almost every 6 months. He was running marathons. He was like the specimen of like the healthy as ever. And he was a ticking time bomb. Thank God he called 911. Thank God he did the steps. And then how we got involved here, which is amazing. So we're at Stanford Medical Center and the cardiologist comes out, and this was all pre-planned, so I knew all this was going to happen. The cardiologist comes out and it's like a 7-8 hour surgery. They hand me a box and they're like, and we're in Palo Alto, California, and they're like, you have to go now to the San Francisco airport and drop this box off. The box was his aorta that we were same day shipping to Dr. Milowitz for this research program. It was like rare they get an aorta. And so my cousin and I are like carrying around my brother's aorta as we're whisking to catch this FedEx flight that's leaving like in 30 minutes, flying down the 101 in the Bay Area, delivering an aorta to Dr. Milowitz. Yeah. And I hear it may still be in the building today. Well, that was the beginning of us in this research program. And immediately, that was 2005, our entire family, and my brother being a litigator, being loud, I'm a bit loud, as you can tell. And we just, at that point, got everybody on my dad's side of the family, everybody who was alive, everybody was getting tested. And everybody was going to go get an echogram, get a cardiologist, wherever they lived. We have family in Idaho, in Washington, California, here in Texas. Everybody's getting tested, and then everybody's getting in the research program here. And one of the things that wasn't said today is, what does it mean to give your, like, to get into the research program or to give your DNA? It's a swab test. Because we had a few family members like giving DNA, it's like they got to carve something out of you physically. It's a little container, it's a little swab test. And a few of our family members were a little slow to go do it. And I think there was a little nervousness of, do I want to know? Do I not want to know? Right? And there was a fear factor. And for us, we had to kind of, rattle a few of our family members along. It's like, knowledge is better. And if you know, then there's something to do about it. And again, kind of going to what Dr. Milowitz says, if you know, there's not going to be this traumatic, issue. You may get tested more. You may have to change some of your lifestyle, some of the sports, some of the activities, but and it shouldn't be a mystery. And so we got in 05. And when we got in, it was told to me, and it wasn't Dr. Milowitz, I forget the genetic counselor at the time. Yes, Ellen Regalado, that's exactly right. And she said, and I ended up being kind of the ringleader in the family, and my brother and I both, but I was the one, probably the main point person. And Ellen told me, you're doing this for science. You may never hear from us again. Like, help us get all your family members into the program so they could do a family tree like that and show, show if you have it, show if you're not. But you may never hear, we may not find the gene. Even if we find the gene, we may not get back to you. You're doing this for science. So that's in 2005. 2018, not 2000, yeah, what year? Yeah, 2018, I get a phone call. And I was a little bit involved with the John Ritter Foundation. I actually did the marathon a couple times just to help raise some money, but I wasn't on the board. I wasn't actively engaged. And I get this phone number from Houston, and it's you get phone numbers, calls on your cell phone, and it's a 713 area code. And I'm like, with no name, I'm like, nope, I hit the red button. And then, the voicemail pops up, and you can see there's a long message. I'm like, oh, this is not a cold call. It's like a serious message about something. And it took me a day or two to probably listen to it. And I listened to it, and it was who would have been then the genetic counsel? I have the email. Maybe it might have been you who called me. That might have been. And so I tell this story. I call the person back. And if it was you, Elaine, you're telling me my family history. And I think I might have been a little rude, so I apologize. I'm like, I know my, yeah, I said, I know my history, cut to the chase. Why you calling me? And there was a pause, and it was, we found your gene. I was like, and then the next obvious question, do I have the gene? Because I'm the only male on my dad's side in 3 generations who so far had been tested every year, but had no signs of an aneurysm. But I was kind of the mystery. Did I have the gene or not? And I did not have the gene. Yeah, the first male in 4 generations, depending on how you look at it. Well, so then all of a sudden it was like, and it was funny, I've been on the board of the American Heart Association in Austin. That same day, there was an event that night, a heart association event, and our kids have cardiologists because they're getting checked because of our family history, and we didn't know. My cardiologist, so I have a cardiologist and a pediatric cardiologist in Austin, and I'm going to this event that they're both going to be there, and it's a holiday event. It was December of 2018. And I know them well from the Heart Association. I know them well from our family, going to their practices. And they came up to me. The 2 of them happened to be together, just catching up. We're having a glass of wine. And I literally found out about an hour or 2 before. And I'm sitting there. I'm like, do I tell them? Do I not? Like, how do I, like, it's kind of, and I told them. And it was like a love fest. I mean, it was like a tear fest. It was like this whole room. All of a sudden, everyone started telling the story. The cardiologist started telling the story. So it was amazing. But then the next question was, okay, I don't have the gene. That's great. And I found out it's a dominant gene. And so my kids, who've been getting tested for a long time, we've broken the gene on my side of the family. But my brother has 2 children, a daughter and a son. And their son, daughter and son got tested probably 6 months after we found out, and immediately found out that my nephew has the gene. My niece does not have the gene. And I heard this, and my brother's a texter all the time, and I think I got a text from him. And then I started feeling like almost guilty, like, gosh, I've dodged the bullet. He had it, they saved his life. And so I was worried of even calling and talking to him, having this awkward conversation, like, man, now your kid has it. And I called him up, and he was almost enthused. And I don't want to say excited, but he's like, it's the greatest news ever, because now I know. It's not that mystery anymore for our family. And he goes and gets tested. He has a cardiologist at Stanford Medical Center. They live in Seattle, but because our family's been going to Stanford, he's bringing them to Stanford. And his son's getting checked now. And it's not a mystery. So I think that all of this is, and it's been said in a few of the speeches today, one, it's the family knowledge, get everybody tested. And people get uncomfortable talking to family about medicine, politics, money, all these different things. But this is one with everybody. It's like rattle the cages, do the research, get in the research program, and get tested. An echogram is a simple little test. So for us, I'm a huge fan of the John Ritter Foundation, Dr. Milowitz, the whole program. I'd love to ask you all to write a check to the research program, to fundraise, to host an event as Meredith, because for us and our family, it's been super powerful, impactful, and for all of you watching on TV or watching on streaming and everybody here, it's important. And it's not just important for you and for your family, but it's important for research. And as you can tell, I get enthusiastic about it, a bit emotional about it, and I'm just glad you're all here listening and digging in and leaning into the issue. That's what I got. Thank you very much.
Welcome back, everyone. We're ready for a second session. And I'd like to make an announcement. We are having a raffle for those of you in attendance. And Jennifer here you can see her standing with the tickets, has tickets. So if you haven't gotten a raffle ticket, let her know. She'll come around and get one for you. And while that's going on, I'll put up the first of the polls for this talk. So the first question is, how often do you visit with the doctor who monitors your aortic aneurysm or dissection? Usually for many people, that would be a cardiologist or a surgeon, but not necessarily. And this is the question number 2. When it comes to checking your blood pressure at home, which of the following best applies to you? You record your blood pressure readings in a log or diary. You check your blood pressure regularly, but you don't write the readings down. You rarely check your blood pressure at home, or you never check your blood pressure at home. And no one can tell, so feel free to be honest. No one can tell which one you are. Not looking. Poll question number 3. When it comes to heart and blood pressure medications, which of these best applies to you? You can choose more than one option. So I take a beta blocker like metoprolol or atenolol. They end in OLOL. I take an angiotensin receptor blocker. It could be losartan, irbesartan, or something that typically ends in the same last letters. I take a blood pressure medication that is not a beta blocker or angiotensin receptor blocker. I don't take any blood pressure medication, or I don't know. Okay, so for those of you who don't know me, I'm Siddharth Prakash. I'm an adult cardiologist here at UT Health Houston. I work in our aortic and vascular disease clinic with Dr. Milowitz and our genetic counseling team, and take care of folks like you who've had aortic dissections or aneurysms or questions about their family history. And Dr. Weigand had given such an excellent introduction to medical care and how we think about aortic disease in the clinic and how we counsel patients that I'm really going to shift the focus here. And the question that I'm interested in answering with you is how do you live an active life with aortic disease? What are some of the things that you can do to stay healthy? And how do we work with you to make that happen? So there are a few principles that come up in our conversations in clinic with folks who are interested in knowing what are the limits that they can push themselves to, how can they stay active and stay healthy, and what are some concerns that we can address together. The first and most important principle, I think, is to know yourself. That is, to make sure that you're getting lifelong regular follow-up of your aortic condition, whatever it may be, and that you understand what your doctors are telling you. If you don't understand, or if there's a gap in your care, to try to make that right. So that's what I work with a lot of our patients to do, because there are barriers to these things. There are barriers that are financial. There are barriers of life where you have competing concerns that you have to try to address, like family and job. And many times there are barriers to understanding. As we said, knowledge is power. So if you're not sure what's going on with your aorta, our job is to help you find the words to ask the right questions and to advocate for yourself. And then understand the status of your disease so that you can take preventative measures. And we'll talk about what those things are that you can do to protect yourself, especially in those that are concerned about being more active. And part of that has to do with knowing how your body responds to stresses, like exercise, but it could also be stresses that happen in daily life. So how does your blood pressure respond to stress? How do you respond to different types of exercise? And how does your body change over time? Can you adapt to those changes so that you can be resilient? So part of this lifelong follow-up we've already heard about. Annual checkups with a regular doctor are super important because we all are vulnerable to the same kinds of conditions that affect anyone, whether you have an aneurysm or dissection or not. So monitoring your general health is an essential part of your aortic health care. And a lot of times we get caught up in you need to see a cardiologist, you need to get scans, and all of that is true, but you also need to do your regular preventative health care. Get your colonoscopy, get your mammogram. Make sure that you understand what is going on in your body, because all of that is intertwined with how your aorta will respond to your chronic health conditions. So, and then of course, we'll talk a lot about blood pressure, because blood pressure is, as Dr. Milowitz said, one of the major risk factors we understand well that affects your aorta. And so you need to understand what's going on with your blood pressure. How often do you need to check it? What is the target blood pressure? You should be able to answer that question. What should the top number be? And then of course, all of the imaging that we've talked about in detail. But you should be aware that for everyone with aortic disease, the answer to what imaging you need is going to be different, because it depends on where in your aorta your aneurysm or dissection is. Some types of imaging work better for aneurysms that are close to the heart, for instance, and others work better for aneurysms that are in the stomach or in the legs. And so you need to understand where that is that you're trying to get the picture, to know what test works best for you. And then each of those places has different tempos, that is, different recommended intervals for screening. And sometimes you almost need to make a chart, because I have folks that every part of the aorta is affected, but we might be more concerned about one part than the other part. So they might need to get scanned there more frequently than in other parts of their body. All right? So, and then the last one is, how do you control the risk factors that can promote enlargement of your aorta or rupture of the aorta? So one of the most common ones that we just asked about was your medications. And indeed, we do recommend that anyone with a diagnosis of an aortic aneurysm or dissection take at least one medication to prevent enlargement or dissection. The two most common ones are beta blockers on the left side of the screen and angiotensin receptor blockers on the right. They work differently, and in many ways they are compatible with each other because they affect different aspects of your heart and blood pressure function. So knowing which ones you're on and what dose you should be on is extremely important to prevent aortic enlargement or dissection. And it's very important to be aware that most people, when we talk about acute aortic dissections, are still not on adequate doses of blood pressure medication. We understand better now what the adequate dose means for an individual person than we did 5 or 10 years ago, due to a lot of the efforts like the JRF and like the American Heart Association in sponsoring clinical trials to understand how these medications actually slow down aortic growth. We're not there yet, but we now understand that each person should have an individualized target for the amount of medication they should be on. There's not a one-size-fits-all rule, and your doctor can help you find out what the right dose is for you. But that is the question that you should be asking when you go to your clinic visit. Am I on the right dose of this medication? Just not being on the medication may not be enough for you if the dose is too low. The other part of it is understanding how your blood pressure responds to daily activities and exercise. Now, there are 3 major components of blood pressure that we now understand are very important for assessing your overall risk due to blood pressure. There's the blood pressure on the bottom in blue that we measure in the office, but this is like the tip of the iceberg, and it can often be misleading. So you should not rely on the blood pressure that we measure in the office to make decisions about your aortic health. The reason for that is that in about 1/3 of cases, that blood pressure is misleading. It's either too high or too low compared to the blood pressure that you would get if you checked it at home. And because of that, it's very important for you to do more work on yourself to find out what's going on with your blood pressure. Home blood pressure readings are essential. And as in our clinic, we emphasize ambulatory blood pressure, which is a kind of blood pressure cuff that you wear for 24 hours, and it takes your blood pressure automatically. It gives you many more readings, and it gives us a chance to understand what your blood pressure is doing during your daily activities, during sleep, and how that might affect your overall risk in terms of blood pressure on a 24-hour-a-day basis. Very different than office blood pressure. And this test is becoming more widely available, and it should be present, we think, in most aortic clinics, but it's not going to be available in a lot of regular doctor's offices or even cardiology offices unless our patients are advocating for it. And so it's my mission and a lot of my colleagues to make this test more widely available to our aortic patients. The last one is central aortic pressure. This is the pressure that the aorta itself actually experiences. And it's different from the pressure that we measure in your arm on a regular blood pressure cuff. There are devices that can now measure this pressure, and it gives you a more accurate assessment of what your blood pressure in the aorta is actually doing to the aneurysm or dissection that you are living with. And this gives us a better readout, what we need to do, what targets we need to reach with the medications. So we really need to measure and treat all 3 components of blood pressure to have a successful understanding and control of high blood pressure. And the targets for each are different. I'm showing them here on the right, and whether they occur at daytime or nighttime readings. They all have different values that your doctor can walk you through. And the other principle is know your limits and exercise safely. So by that, it means that there are some common sense things that you can do to lower your risk when you're doing any sort of repetitive exercise. The first is limit the repetitions to avoid fatiguing. There's good data that if you are exercising to the point that you cannot do another repetition, your blood pressure is going to be very high. And that, of course, poses a risk for you over time. So you want to stop before those last 2 to 3 repetitions where you are exhausted. The second, avoid straining in your chest or abdomen. This is also known as the Valsalva maneuver, and it happens when your mouth is closed and you're not breathing and you're straining in your chest. That pressure buildup, it turns out, affects the blood vessels in your chest and abdomen. And that includes the aorta. So that if you have a weak aorta, that's putting it under high stress. There are ways to do the exercise without doing that maneuver. If you control your breathing or you use limited weights so you're not straining your chest or abdomen. If you want to, in that case, lower the intensity, moderate, not strenuous intensity exercises, and not sudden bursts of activity, but a slow, steady tempo. Those things can limit the wear and tear on your blood vessels. So we at UT Health, as Dr. Milowitz mentioned, have been interested in this problem. How do we get information to patients so that they can exercise safely? And how do we then assess whether exercise can actually be used as a treatment for aortic disease? We know in people without aneurysms and dissections that exercise can lower your blood pressure, prolong your life, and reduce the risk of things like a heart attack or stroke. The question now is, can regular exercise actually reduce aneurysm enlargement and reduce your risk of rupture, as it was shown in some of the mice with Marfan mutations, for instance? So we have been exercising people who volunteered in our clinic, and we recently reported a study of the first 50 patients. We found that people with aortic disease, including aneurysm and dissection, can effectively perform most of the moderate intensity exercises that we tried. We tried a set of 6 exercises that we think represent common things that people do at home, like treadmill, curls with small weights, and other forms of low impact exercise. We also found that people who reported doing these activities on more minutes every week actually had lower blood pressure responses to exercise, indicating that training can actually improve your results over time and reduce your risk of high blood pressure. So we're taking this to the next step, and I'm very pleased to report that our group was awarded a pilot clinical trial grant to run a study, a 1-year study of exercise in patients who survived an acute aortic dissection. We have brochures outside on the table that we'll be able to share with you over lunch. But the idea is that we're going to do a randomized controlled trial of clinical guided exercise program that people can do at home. It doesn't involve fancy equipment. It's something that you can self-monitor, and we will be following up with people who enroll for a year, determining how it affects their mental health, how it affects their quality of life, and eventually we want to take this to the next level and see how it affects their aortic disease as well over time. So we'll be signing up people for the trial. If you're interested, there'll be a sign-up sheet outside. Thank you.
Great. Morning, everyone. Let me just get some poll questions here. Great. All right, I like that answer. It's all of them. Spoiler alert. Very good word choices here. I've seen these words a lot. So I think those were just the only 2 that was in. All right. Okay. All right. Good morning, everyone. I'm Dr. Irvin Salapis, and I am here to discuss more from the emergency room primary care perspective. I am a primary care physician, and I'm also a sports medicine physician here at UT Health. So all these talks about exercise after surviving, especially in the pediatric and the adult talks were great. So thank you for those. And my near and dear sport, I am also the one of the medical team captains for the Houston Marathon. So we've heard lots of stories of aortic dissection, survivors who have gone to run 5 10Ks. I know there was the Aortic Health Run just last weekend, right, in Fort Worth. Sorry for exciting. And in our sports medicine world, there was a big news in our society that there was a aortic dissection survivor that actually completed the Boston Marathon last year. Now, obviously, if you guys aren't runners, you have to really be fast to qualify for Boston. You have to be a sub 8-minute miler. So he qualified and then had his aortic dissection. Yeah, and he actually ran the Boston 5 months after his surgery. He was taken care of Cleveland Clinic, and with his cardiologist and follow-ups, they, Had him cleared, and obviously he did not have that Boston time again, but he already qualified, and he did finish in like a 10:30 minute mile pace, which is still fast. I'm a 12-minute mile guy, but regardless, that was a big story of you know exercise after dissection. So just a little tangent. All right. All right, so identifying patients at risk. We've heard of this a lot from the previous speakers, but besides primary care work and evaluating as a sports medicine doctor, I do a lot of sports physicals for the youth and also take care of collegiate and professional and Olympic athletes. So that big question of, does any of your family members have died from a heart condition under the age of 50 is the number one red flag for me to ask more questions or do further testing. In a primary care setting, or if I'm the hospitalist, hearing something from the ER to potentially admit or evaluate a patient, I always have to consider aortic dissection. If any patients are having, like that severe chest pain, the key, you saw those word clouds, severe, key is severe, tearing, ripping apart, pain is radiating to either my neck or it's like a dagger going straight to the back. All right. If they had fainted or what we call like a syncopal episode, stroke-like symptoms. We call it acute mental status, but if you feel like something ain't right, like they're losing their train of thought, their speech, they're starting to murmur, or they just look like their mentation state's going a little low, consider into what we call the differential. Feeling like a heart attack. That's always the most common thing. I feel my chest pain. Is this a heart attack? I don't know. I should go to the ER and get evaluated. Even then, if it's still severe, I'm still gonna, aortic dissection is life-threatening. That's on the top of my differential unless otherwise noted when I do further testing. Other things that people may not think of, leg or arm pain. We always tell, watch for stroke, or chest pain, left arm tingling. It could be right arm tingling, or like I feel like my right leg is cold or my left leg is cold. One of the symptoms of a possible aortic dissection is that like the pulse pressures on the limbs are a little different than the other arm or leg. So risk assessment for aortic dissection. Anyone with any connective tissue diseases like Marfan's or Loeys-Dietz or Ehlers-Danlos, we call those syndromic kind of diseases. Family history of aortic disease. It is autosomal dominant, so having a good family history is always important. If you actually know you have aortic disease, if you present to the ER with chest pain, please tell the EMS, the paramedic on the way out, the ER doc, the triage nurse, I have the thoracic aortic aneurysm. That changes the minds quick, and we know what the next steps to do. Recent bypass surgery is also high risk as well, and much for known aortic aneurysm. So on exam, when we see these potential patients, they have pain. It's sudden onset. So they mentioned it's severe, that ripping or tearing like in quality. The arms or legs feels different. They seem like it's tingling or feeling cold. When we check pulses, sometimes there may be a decreased pulse sensation compared to like one arm to the other. We can do blood pressure checks on the right arm and the left arm, and sometimes we can see a difference in the blood pressure reading. So those are all kind of signs that we're thinking like, hey, this could be an aortic dissection. We need to do some further testing. Blood pressure can be low, and that can kind of coincide with the fainting or what we call the syncopal episode with these patients, and then that altered mental state. They just look like they're somnolent, they're drowsy, or they're saying words and they're not really combining together. Those are signs that we need to further assess and do some further testing. With testing, I've mentioned before in previous talks here, in an emergency setting, probably order x-rays or an EKG, but it's not going to show dissection. Yes, the textbook answer, a chest x-ray, you can see what we call like a widening of aorta, but to really diagnose aortic dissection, CT scan, an echocardiogram, which is the ultrasound of your heart. Particularly, we call it a transesophageal echocardiogram, where they put the down the esophagus to really look, and also an MRI. You guys have this in this card, right? There's these things called the Ritter rules. Sorry for the formatting on this slide, but it's these rules that were established about, was it 12 years ago? Was it 2010, I believe? The first, yeah, I remember the big ACC the article then, and has since you heard it here first, guys. Oh, yes. So there will be a 2022 update. Stay tuned. The Ritter rules state that, urgency is key, right? The death rate increases with aortic dissections 1% every hour the diagnosis is delayed. This is a medical emergency. Pain will be your number one symptom, and it's gonna be severe. Pain tearing through, radiating to the back of the neck. Could be misdiagnosed, it can mimic a heart attack, but when it's severe and that tearing or ripping apart sensation, dissection's the top of my thought process until I rule that out. Imaging, talked about CT, MRI, echocardiogram. CT is faster. MRI, and the cardiologist can speak for me on this, but in an MRI setting, usually is with follow-up or pre-diagnosed, not necessarily an emergency setting. MRIs take like 30 to 45 minutes. When it's a medical emergency, you get a CAT scan. Risk factors, history of aneurysm, family history, any genetic syndromes like Marfan's, Ehlers-Danlos, and also what we call a bicuspid aortic valve, meaning that the valve, the aortic valve typically has 3 valves in it, and there's just 2. Triggers, lifestyle, sedentary lifestyle, or another is trauma, like a motor vehicle accident that, so not necessarily like genetic or anything, it's just a bad, motor vehicle accident, bad trauma accident that created an aortic dissection. And also prevention. Controlling blood pressure. Dr. Prakash had a great slide on the medicines that are typically used to help control blood pressure, getting aortic imaging, an MRI, or for serial monitoring, and if it is, and genetic counseling to make sure that if it is a genetic condition, then the family history and the family tree will really need to be delved out. Well, that's all I have for you guys. Thank you.
So I do have some questions here that poll questions that we'll go through. And I think we'll do this first one. So after surviving surgery for acute dissection, type A or B, what was your greatest challenge? And this really points towards those who've had a repair. So the physical recovery, mental recovery, anxiety related to possible recurrence of disease. Very interesting. So 16 votes gives me an idea of what folks are concerned about. We'll go on to the next one, which is what aspects of your life have been impacted by the diagnosis of thoracic aortic aneurysm or dissection? You may choose more than one. So the mental health, anxiety, depression, post-traumatic distress syndrome, substance abuse, developmental life stages, missing out on opportunities, relationship. Is this my question?
That's my question.
Okay, I'm sorry. It sounded familiar, but we'll go ahead and do it anyway. That's a good question. So actually, I didn't mean to steal your question there, but that's a good question. Okay. It shows you how many times I looked at my questions. That's a very good question. Okay. So how about this one? Do this one. I'm just picking them. Now, after surgery for aortic aneurysm section, what did you look forward to the most? Eating, walking, sleeping, using the bathroom, taking a shower. Very simple questions for those who've had an operative repair. Looks like taking a shower. Taking a shower. Interesting. Taking a shower. Okay. Go back down here. Let's try this one. Third one. After surgery for thoracic aortic aneurysm dissection, during your recovery in the hospital, whom did you look forward to seeing the most? Spouse, friends, nurse, physical therapist, cardiologist, food, wife, surgeon. Oh yeah, food delivery. That's going up. Yeah, there you go. That's the one vote. Good. Food delivery, number 2. Interesting. Oh, thank you. Okay, after you had surgery for thoracic aortic aneurysm section, what did you wish you would have? Hold it. What do you wish that you would have inquired more about? What to do to prepare for surgery, what type of operation I would have, knowing the details ahead of time, what to expect immediately post-op, waking up in the ICU, what to expect in the hospital once I had been discharged from the floor, what to expect after discharge, or something else. So, what to expect immediately post-operatively, what to expect after discharge, something else. Very interesting. For those who don't know me, I'm Tony Estrella. I'm one of the cardiothoracic and vascular surgeons here at UT. I want to thank the John Ritter Foundation. I want to thank Diana and Siddharth for the invitation to speak to you today. This is all about you, the patients. So I want to thank all of you for your participation, in this great symposium. Amy couldn't be with us, but I want to give her a hard time for not being in Houston. So be it. I'm sure she's listening, so you hear me well, Amy. But I met Amy in 2003. I think it was in the end of July in 2003 when she, John had his dissection and she wanted a little more information about this condition. So I actually was going out to California with my wife for vacation for a few days and had a chance to meet with her. And, I didn't know what to expect when I met her, but we met and I brought my little laptop and showed her on my laptop, what dissection was and showed her all the aspects about surgery and things. And I sort of scared her a little bit with all the gore and blood and guts and all that stuff. So I'm not going to do that today as a surgeon. I'm just going to really talk about, what I've learned over the last 25 years about surgical perspectives on aortic dissection as it relates to the patient. All right, with that, I'm going to get on with my 7 minutes of discussion here, and I really am going to keep it very general. Again, no pictures of operations or things. We can leave some of those questions for the panel discussion. But really, what I've learned over the past 20, 25 years about aortic dissection as a surgeon, and what I want to relate to you guys, as well as what I relate to some of my patients here, really on a regular basis, is really the topic of my discussion. And when we talk about surgery, what I tell all the patients, to this day is you were hit by a truck, with aortic dissection surgery, just in general, whether it's elective or operative. This is a big trauma. Right now, there's really two kinds of procedures we do. The invasive standard open repair, which is the open repair for the ascending aortic root, the proximal aorta. That's open heart surgery. That's a big insult. You got hit by a truck, is what I tell the patients on a daily basis, and it takes time to recover. You also have the less invasive, also the minimally invasive endovascular stent grafting, which is applicable to some patients. I ask you to really do your research when you're talking about the elective situation, and maybe some patients can be treated with an endovascular procedure, which is basically a catheter procedure that goes up through the groin artery, and you deploy a stent on the inside that seals the aneurysm or the dissection off. There's a lot of advancements that have been occurring in this area, but I will say that open repair, especially for younger folks, and for when you're dealing with the ascending aortic root, is still the standard type of procedure we're going to be doing for this for now. I think with advancements in technology, this could change over the next 20 to 30 years. But I just want you to keep that in mind in general. And when you have a type A dissection, Meredith suffered from a type A dissection, you were hit by a truck twice. That's the reality, because what some of my patient this morning I was surrounding with, I said, you got hit by a truck, and he said, yeah, and you ran me over and backed over me at the same time. So it is true with dissection, because you have the trauma of the actual dissection. Because even with type B dissection, what we see is a big inflammatory response. So patients with type B, or when the descending has a dissection, even though they didn't have surgery, it's still a big trauma, because you think about the aorta tearing, it sets up this big inflammatory response for the whole body, as if you had surgery. So in those situations, if you have a type A dissection, you get that aorta torn, sets up this whole inflammatory response, and then you have surgery on top of that. So it is a lot to recover, and it does take time to recover from this. Let's see what my next slide is. What I mean by sweat the little things is, when you have surgery, it's very interesting. We talk about the major complications when we're talking about surgery with a patient. And the patients in this room know that I've had this conversation about what to expect. We always focus about the big things, the mortality, the risk of stroke, the risk of needing dialysis, the risk of needing a tracheostomy, pulmonary failure. All these are real risk. And these are the ones we talk about, and these are the ones that are reported in the literature. But there's also a lot of other risk, a lot of other issues that patients go through once they've had surgery. It's very interesting. And some of these more subtle complications, and although minor and patients oftentimes recover, it's something that I think it's important to let patients know what to expect. For example, taste of food may be off, for a few weeks. I always, as a positive, say that yes, the taste for food may go away, your appetite goes away for several weeks, but all the patients enjoy the fact that they lose 5, 10, 15 pounds, for the first couple of months. And that's a reality from this kind of surgery. Sleep patterns, may change right after surgery. Another thing that oftentimes happens, it's not that can occur frequently, is that your temperature gauges are off. Remember, with these open heart surgery circulatory arrest cases, we actually cool the body down to 20 degrees Celsius, 70 degrees Fahrenheit, stop the circulation, provide blood flow to the brain and the organs, and then replace the arch and do whatever we need to do. That can reset your temperature gauges in my mind, in your body. And so some patients will complain of, or be worried about, waking up in a sweat at nighttime, or have sometimes the feeling where they're always hot or cold. And these subtle changes take usually 4 to 6 weeks to eventually recover from, and then they get better. But these are little subtle things that will occur after surgery. So as a patient, try to inquire and be familiar that there will be these changes that occur for several weeks after surgery until you're fully recovered. Set goals. Keith Isbell was a patient, of mine who had a surgery for an aneurysm in a valve, and he was a very big advocate about getting the message out on getting your aneurysm repaired. He did not have a dissection, but he did have an aneurysm and a bad valve that led to a stroke, which then led him to me. I mentioned his name. He's given me permission in the past. He has since passed away because of throat cancer. But he created a very neat video a number of years ago that I always refer some of the patients to, and you can look it up on YouTube. I think it was Heart Surgery Isbell, something like that. If you put that on YouTube, you can find a video. But it's actually a very professionally done video that goes through his experience with having open heart aortic valve surgery. And one of the messages that I remembered from his video was the fact that you need to set goals. So this guy was very active, but he mentioned that he would get depressed after surgery and that he had to push himself to set goals for himself, first small goals, then larger goals. And he made a goal to climb one of these, I forgot the name of the rock out west, Fredericksburg, something like that. Enchanted Rock. Very good. Yeah. Enchanted Rock. He set a goal to climb that rock, by week 6, and also set another goal to take his family to Disney World, which is what he did. But it was as a patient going through these surgeries, especially electively when you can prepare for it, I think it's important to remember that point. Set a goal for yourself so that it gives you something to look forward to, something to work towards. And I think that's a very important point as a patient. I think I always say this to all the patients that I take care of, share your experiences. That's the whole purpose of having this forum, is so that everyone can share their experiences. And I'll tell you, 20 years ago, there wasn't access to what we have now. I mean, with social media and all the work that the John Ritter Foundation has done. And I always recommend my patients to go to the website because, you want to make sure you're not alone in this. And a lot of patients don't realize what support there is, what, the support groups, advocacy groups that are available, for patients with aortic dissections and aneurysms. I mean, it is growing. It's continuing to grow. And I think, through the work of the John Ritter Foundation, it will continue to grow over the next several years and provides, comfort, to patients who have had aneurysms and dissection to know that they're not alone. Let's see here. You're not alone. Surveillance, it's all about control. We always want control of our lives. That's where the surveillance becomes important. That's where, if you've heard a lot of great messages this morning about, imaging, about genetic testing, Greg's brother is a very important story there, message there about realizing once they knew the gene, they could own the process. And I think that becomes really, really important. Also, with that control, it allows you not to let the disease imprison you, because this is a condition, it's a disease. It's very easy to be imprisoned by this, where you're so fearful about doing anything. But knowing that you have it, knowing that there is things we can do to treat it, should empower you. You've heard that term a lot. Should empower you to be able to own the disease, really take control, of your life, in this. And I think that's a very important point. Um, with that, I want to also thank, Diana and Prakash, and again, the support of John Ritter Foundation for a lot of the work that's been done in the research aspect. In the 23, 25 years I've been doing this, it's amazing to see what has happened in this field that have allowed us to really take control of many aspects of aortic aneurysms in the section. And I'll leave you with this one story that you saw one of the genes, PRKG1. It's a very interesting story. A family, a woman, a mother, was led to Dr. Milowitz, and she was from New Mexico, maybe 2 or 3 years ago. And her husband had died of an aneurysm in the section. She had 3 kids. Her 2 older sons in their 20s, late teens, 20s, had died of aortic dissection. And now she had a 16, 15-year-old daughter left. And this always reminded me of the story, Saving Private Ryan. You remember that movie, where the 4 kids and 3 of them had died in the military, and they sent Tom Hanks to go bring the last son, home. It reminded me of that story because they analyzed this young girl, and her aorta was completely normal. It was 3.2 centimeters or probably 3 centimeters in diameter. No issue. There's no indication that the traditional indications for surgery we should operate, But because of the work that Diana and the group had done to identify this gene in this young girl, it was a no-brainer in my mind that she needed an operation. We had to stop the cycle there. And so she underwent a valve-sparing route, and she did great and went on to high school and everything. But that story just makes me think about the advancements in medicine and science that eventually will get to a point where we have the tools to identify specific genes in patients that will dictate, how they will do and what we should do. And it's really exciting to be in this field, as a cardiovascular surgeon, and be able to know and have these tools in our armamentarium so that we can honestly help patients and prevent, these complications from occurring. So with that, I hope, Amy, you were listening. I'm really disappointed you weren't here. And I'm going to give you a hard time the next time I see you. But with that, I thank you for your time and look forward to the panel discussion.
So I'm going to look through my poll questions, one of which has been posted a couple of times. Maybe I should skip that one. Let's see. Okay. So where do you seek emotional support to strengthen you and help you cope or adjust? Okay, I'm going to go on to the next question. Have you sought counseling services from a mental health professional? And I think the last one we have already, what aspects of your life have been impacted by the diagnosis of thoracic aortic aneurysm or dissection? And this has been, okay. Great. Good morning. I'm very pleased to be here participating in this symposium that addresses the needs and concerns of those of you living with the prospect or with an actual diagnosis of aortic dissection or aneurysm. In my 40 years being a mental health professional, inclusion in a medical symposium has been the exception rather than the rule. It is reassuring to see that mental health is considered and included as an integral part that it is in our well-being, our health, our quality of life, and in this case, in cardiac rehabilitation, because the mind and the body are one. Thank you. Okay, so part of my role as a behavioral health counselor at TIER Memorial Hermann consists of helping individuals and families facing or adjusting to new onset or long-standing catastrophic injuries, trauma, including spinal cord injury, traumatic brain injury, strokes, amputations, cancer, and rare neurological disorders. In my 13-year journey in this role, a catastrophic diagnosis, which certainly AD could be considered as such, has definitive implications, not only from a physical standpoint, but also from a psychological and emotional standpoint. So from the time of diagnosis, through hospitalizations, through surgeries and treatment, life as you knew it before this diagnosis is irrevocably changed. These changes affect every single aspect of life. As families and individuals, you're called upon to redefine your roles, priorities, time, financial obligations, resources, and called upon to acquire strategies and skills to address these problems that you never even thought possible. Dealing with a catastrophic diagnosis can potentially bring about a secondary crisis that must be addressed in the overall treatment plan. And this includes short and long-term physical and emotional sequelae that could qualify as medical trauma. So medical trauma is defined as a set of psychological and physiological responses to pain, injury, serious illness, medical procedures, and frightening treatment experiences. And medical trauma can result in clinical psychiatric diagnoses such as anxiety, depression, post-traumatic stress disorder, and an increase in use or abuse of alcohol or illicit substances. In the case of AD, beyond the shock of the initial diagnosis and acute event, there's then the likelihood of additional surgical interventions, the need for ongoing monitoring, the psychological burden of figuring out a new normal for yourselves and your family. And all of this can be quite taxing and emotionally oppressive. Anytime you're diagnosed, like all the other speakers have talked about, because part of this could be, well, there is the familial issue. This gives you pause, whether you're trying to start a family or you already consider the family that you have. There's an impact on all these inherited disorders. It robs you of the spontaneity that characterized life before you were diagnosed with a disorder like this. This interferes with the flow of life, the life you had envisioned for yourself, the inevitable missed opportunities that rob you of the spontaneity that you had before. There's no denying that any impactful diagnosis also places a burden on your family, your spouse, your significant other. Patients usually mention the burden that they feel that they are on their spouse, predominantly their spouse, but also their extended family. When you face a diagnosis like this, there is also a change in your perception of yourself. As a desirable person, your sexuality suffers. A lot of studies mention that AD places there's a decrease in sexual activity, in sexual interest, and it certainly is, many of the patients report that AD negatively affects their sexual activity and sexual interest. Dealing with a diagnosis like this can become so central and all-consuming that you neglect and social interests become very unimportant, if important at all. So there is that social isolation part. I imagine that through COVID, this was even made worse because you were very careful to go out and be exposed so that on top of everything else, you did not want to acquire COVID. So I imagine that these last 2 years have been rather trying, not just for all of us, but for you in particular. Depending on the severity of your individual case, you may have to take absences from work, or in some severe cases, folks have to file for disability because they can't continue to work. Treatment is expensive. There are financial concerns, issues with insurance coverage. It's always a headache. And all of these adds to the stress of dealing with AD. In the physical realm, the body becomes kind of a different entity after AD. The research mentions a sense of hypervigilance, constant monitoring of your physical body, scanning for symptoms. Lack of trust in the body is mentioned also in the research. And you might start to see your body as a separate entity, not entirely within your control. There is uncertainty about whether your body is going to be able to perform and withstand the rigor of everyday life that before this diagnosis was no big deal. There's the issue with pain, fatigue, and the obvious physical limitations also. When our life is threatened by an adverse diagnosis, we inevitably wrestle with issues related to death, freedom, isolation, and the meaning of life. And so our priorities shift, and so does our life's outlook. Research shows there is an incidence of 32% for both depression and anxiety after a diagnosis of AD. There's PTSD in 12 to 25% of folks also. Now, there's some questions to ask yourself, and these were some of the questions that I posed in the poll. So we've covered some of this already. But what do we do with all of this? And this is the message that I want to leave with you this morning. So at the heart of dealing with a diagnosis like AD, let's talk about building resilience. So what is resilience? Resilience is the capacity of people to effectively cope with, adjust, or recover from stress or adversity. At the center of resilience is self-efficacy, and that refers to one's confidence and personal agency and self-determination to exercise control over one's life. Is that how willing are you to take this bull by the horn? This brings us to the concept of managing your disease. So this refers to the management of a chronic condition over the course of a lifelong illness. And why is this so important? Because when you think about managing this issue, this puts you back at the driver's seat of your life. We all manage our careers, our finances, our families, and our personal lives, and this is no different. Disease management entails active participation on your part and partnering with your physicians and other healthcare professionals, family members, and extended networks to adapt and maintain long-term health habits, prevent further progression of your disease, and improve your quality of life. So you need to face your fears. It would be unnatural to be faced with a life-threatening diagnosis and not have these emotions of anger and fear and depression and even some post-traumatic stress. This is the way we're wired. We respond to stress, and this stress and this anxiety that we experience can be guiding and point us to paths to take to resolve it. It's not so much that you have these strong emotions, but how you manage them that is critical to adjustment. So information is power. We've heard that from each and every one of our speakers. The more you know about your particular entity, how this is manifesting, what part of your vascular system, where, how severe, implications in terms of all the medications that you take, the more you know and can take this bull by the horns, the better off you will be, the better off you'll be able to direct your care and partner with your physicians to address your specific needs. You also need to know if you're having anxiety and depression or post-traumatic stress disorder and how this is manifesting in your lives. I have a handout that I will have at the end, and there are any number of websites that I have listed for you there so that you can go and identify and even take maybe some quizzes to see if you are experiencing anxiety and depression. And if you are, mental health has come a long way in 40 years. It used to be hush hush, and if you were depressed and had a diagnosis of depression, this was just not to be talked about. And some people did not seek care because they were afraid of the ramifications of having a diagnosis like this on their insurance. That's not the case anymore. There is psychotherapy. There are wonderful medications to help you, just like you take medications for high blood pressure and diabetes. There's medication for anxiety and depression. And you want to not take the tiniest little dose, which is what I struggle with a lot of my patients. Oh, I just want to take the lowest dose. No, you don't want to take a subtherapeutic dose. You want to take the dose that you need to address whatever it is that you're experiencing. These are all treatable entities, and they are very much a part of what you're dealing with. It's important that we learn to reframe stressful events and to find the silver lining in these adverse experiences. There is such thing as post-traumatic growth, and that is the new person that we become after we experience adversity. Again, the more that you know about your disease, the better off you will be. You will have to bring about some changes in lifestyle. You need to mobilize your motivation and your perseverance required to succeed. Yes, you are waging a war. This is very challenging. You need to learn to become temporary setbacks, and there will be setbacks, and you need to be able to have that self-determination to set goals, stick to them, and maintain your new behavior. This is all part of disease management. When we talk about acquiring new skills, I'm talking about problem solving, decision making, resource utilization, communication with your physician and your significant others. So many times I hear patients tell me, I don't want to worry my wife, or I don't want to tell my husband or my children. No, we are not wired to go through adversity alone. We are born into families. We are born into communities and into society. And you need to tap onto the strength of your social networks to pull through this life-changing experience. For you, those of you who are caregivers and family members, it's also very important that you become familiar with the manifestations, the symptoms of your loved one's disease. Why? Because you live with them, and sometimes what they are not able to detect in themselves, you will. It's equally important for you in your caregiver role to address your own emotional and personal and physical needs. So a lot of times caregivers neglect themselves because they're so consumed with the care of the other person. You can't do that. You won't be around then to be able to lend support to your loved one. The other part is I recommend that you join a disease-specific support group. There is an advocacy group. There's a lot to learn in their websites. And it's also in joining and share your story that you are better able to deal with what you've gone through. I cannot overemphasize how important exercise is. And this has been discussed. It's also part of mental health. We are meant to be active, to activate our bodies. That's how we find the sense of self-agency and how we feel more in control. Research shows that you are 50% more likely to have new onset major depressive disorder after a diagnosis of AD if you do not exercise. 50% more likely. So you need to keep active. You need to find out from your doctor exactly how much you're able to move, to what extent, what kinds of exercising, but get cracking and get moving. Being sitting like a couch potato is the enemy. In closing, just like you address the physical aspects of AD, you also need to address the psychosocial aspects, and they can be addressed through a mental health professional. For those of you who've never been to therapy, counseling can offer you a forum for you to explore and express your feelings, your emotions. You can hear yourself talk out loud. You may have had these thoughts a million times, but it's a totally different experience when you get to hear yourself say what you are thinking. Therapy is also a place where you can learn. What can you learn? You can learn first and foremost about yourself. You need to know yourself. You will gain insight. You will gain courage. You will also gain new skills, because that's part. If you go to a therapist where you sit and you just pour your guts out and you don't get any feedback, run. You need to find somebody that you feel is there with you, listening to your story, giving you feedback, giving you information, challenging you, supporting you, confronting you when she or he has to. You don't want to have somebody who says nothing or who says whatever you think you want to hear. So you want an advocate, but you want somebody that challenges you and that you feel is there for you. So there you have it.
Thanks again to all of our wonderful speakers, and I'd like to announce a schedule change. So we were going to head directly into the panel, but seeing as it's late, and I'm sure you're all interested in lunch, I think we have lunch outside, and I think it would be better for us to break, get lunch. We can bring it back into the room and then proceed with the panel discussion then, while we're all having lunch. Does that sound okay? All right. So let's do that next.
Okay, everyone. Thank you. Thanks to everyone who submitted questions on Slido. And I just wanted to comment that we received a lot of good questions. We probably will not be able to address all of them, and some of them are specific to genes or recommendations, for you or your family. So if we cannot address them, we can follow up with you individually, and you can certainly reach out to us at jrrp.research@uth.tmc.edu, and we'll put that email address up. It's also been posted in the chat, but if we can't get to your question, we're happy to address individually. So thanks again to the panelists, the speakers for sharing all of the fantastic knowledge that you have. And we received a lot of questions about screening, which is good, and family history and the utility, the importance of screening if you have an aneurysm or dissection. And one of the questions generally related to screening for aneurysms and dissections outside of the aorta. So should people be doing imaging for brain aneurysms, and how often that should happen if there's a family history of aortic aneurysm and dissection? Dr. Milowitz, could you comment on that?
Okay. So if your family has members with aneurysms, thoracic aortic aneurysms or aortic dissections, you don't have to worry about aneurysms elsewhere in the body. If there's a history of aneurysms and dissections, and then also intracranial aneurysms, then we go ahead and scan for those intracranial aneurysms also. But the vast majority of the families will just have thoracic aortic disease and not have aneurysms elsewhere. And then with some of the specific genes that were on that long list that cause disease, especially those that fall under a syndrome called Loeys-Dietz syndrome, those people can go on to have aneurysms and dissections elsewhere. So even without a family history, if you have one of those gene mutations, then we would go ahead and do baseline screening from head to pelvis to look for other aneurysms. But your typical patient with an aneurysm or dissection or a family history doesn't need to worry about it.
That's great. And I think that relates to the research that's being done here, which is the goal being that if we identify the gene, then the recommendations for screening patients and family members are specific to that individual gene.
Right. And so the gene will make a difference as to whether we look for those other aneurysms, but also the type of vascular disease that we look for, because other genes cause thoracic aortic aneurysms and dissections, and along with early onset heart attacks. And so we have to screen for coronary artery disease in those individuals.
Great.
So the gene will dictate all of that. And like Tony mentioned, it becomes very powerful information for you and your family.
Dr. Estrella?
I just wanted to add, this symposium's, we're focusing on thoracic aortic aneurysms and dissection, but we also have to remember that one of the most common aneurysm location is the abdominal aorta. We call it the infrarenal abdominal aorta, or AAA, you'll hear the term. And although this is not the focus of this, the government, Medicare, will sponsor for ultrasound surveillance of any man over 65 who has a history of hypertension to get a screening ultrasound. So it tells you how predominant AAAs are. And we're not really talking about that here, but I just want you to be aware, of the fact that AAAs do occur quite frequently, especially in men and women, to be honest with you. Yeah, the stomach. So in the stomach, around the belly button. So this is not really dissections and aneurysms up where we're talking about, but that is actually more frequent than what we're really talking about here. So just keep that in mind.
That's a great point. And I think one of the takeaways that we got from Bella's presentation and Dr. Milowitz is that sometimes the gene can't always be identified, but family members still need to be screened. And a common question that parents often have is if the gene isn't identified and there's a family history, when do we start screening our kids? At what ages?
It's a great question. Thank you for that. If there's no gene identified, but there's a family history of aortic dissection, we see a fair amount of that come through our clinic. And I think what we'll do is absolutely do our routine kind of screening by echocardiography on those patients. If it's normal, i.e. there's no root dilation, no ascending aortic dilation, we don't discharge those patients. We know that the family history, albeit we have not been able to put our finger on the exact name, and as we know, we're all learning so much more as the years go by, we advocate that we don't discharge those patients. And so the frequency with which we see them back, if their echo is normal, can vary, I think, between provider. I would advocate that, especially if in their years of rapid growth, i.e. their teenage years, to see them every 1 to 2 years for sure, at minimum. A lot of that also has to determine too, I mentioned in my talk about this is an evaluation in evolution. So if we start to see concerns based on a child's aortic dimensions by echocardiography, that frequency may change, get closer and closer, especially if there's a family history such as dissection. But I think the history is so valuable, and even if we can't put our finger on the exact gene, those children warrant the pretty close follow-up.
That's great. So the takeaway is take your kids to see the pediatric cardiologist to get screened. And even though their aorta may be normal at the initial screen, do follow up and just heed to the recommendation of that particular provider, and recommendations change over time. So a few of you commented on ways that we can prevent these dissections from happening, right? Via screening and staying on top of all of this. What is the best predictor of dissections, particularly that we've heard a few stories of patients who've had dissections without aneurysms? Is that aortic growth and measurement still a good predictor? And how should we be using that to know when to send patients to surgery?
I'll take a stab at this one. So as many of our speakers noted, a family history of dissection is still the best predictor that we have overall. If we have that, although it's not always present, if it is there, that's a strong indication for us to increase the surveillance of that person, to increase medical therapy. Frequency and intensity of the treatment would increase based on that result. In terms of the size, what we advocate is not to use the absolute diameter of the aorta as the best predictor. There have been many studies showing that adjustment of aortic size to body size is a more accurate representation of how large the aorta is for that particular individual. That's particularly true for women, people with smaller body surface area, smaller people, who don't necessarily have large absolute numbers when you look at the measurement. But if you adjust it to the fact that their bodies are smaller, it comes up to be an aneurysm. And that's frequently a source of confusion with our patients, and something that I try to educate our patients about. It's more often used in pediatrics, but it's becoming routine to use these in adult aortic centers. And that can provide us with additional information that this is an aorta that we need to watch carefully, because the dissection risk may be higher than we initially thought.
I'll echo those thoughts, Dr. Prakash, because I think it's important as we adjust everything in our pediatric age group to body size. It's also variable amongst patients of different ethnicities and backgrounds and heritages. So a patient of Asian descent per se may not have the same tall. We talked about kind of the tallness, the tall body stature or body habitus with which a lot of patients are referred. Well, that can vary amongst patients of Hispanic and Asian descent, where they may be under-recognized because of that. Size matters. It's not the only thing that matters, is what we're coming to learn. And that's one of the things that's exciting about the future, is we're starting to try to find different biomarkers, different imaging markers about the aorta that can clue us into risk of dissection. And we know that patients can dissect at diameters smaller than what we would have anticipated. So this is something that we're looking into as a field, as a community, to try to identify other things that can help in a risk prediction model.
Thank you for those responses. And I think that the providers here have probably all gotten feedback from patients along the lines of, even though I know that I'm at risk for dissection now that this aneurysm has been identified, I feel that I have a ticking time bomb in me. And it would be helpful to hear from perhaps Dr. Estrella and Greg and or Bella with regard to what information you take into account when you're counseling patients about whether or not to pursue surgery and when.
Yeah, I think that's a very important point, because every patient is different, and you have to individualize, the treatment for surgery. I completely agree with what the guidelines state, and what has been stated here. But I also take into account, that counseling session, that discussion as a surgeon, and try to make these decisions you have with a patient. I agree with Prakash. Family history is very important. The genetic makeup is very important, but also, the patient's, anxiety related plays a part. The patient's longevity. A simple question I always ask the patients is, how long did your parents live? If I'm faced with a 70-year-old patient whose parents lived in their 90s, that means that patient has probably at least 20 more years or longer of life. And if you think about the numbers, if someone has a 5 centimeter or 5.2 centimeter aortic aneurysm, then there's a significant risk that will dissect or have an issue over the next several years. And so that comorbidities, all these factors, play a part in the decision, in the shared decision, we make with the patient about having surgery. And that's important, really to take that time as a surgeon, when I talk to these patients.
Yeah, Bella, please.
I wanted to add on to that, that I think a lot of the patients get stuck on the numbers. So they say that the surgery threshold's 5 centimeters. Why aren't we moving forward? And so that comes into play if you have a known gene. We have some data to say when we can intervene if you have a known genetic mutation or variant. But for the families that don't, where we don't know your gene, that's where I was saying that we could incorporate family history. So if your family member had an aneurysm that grew to 7 centimeters, that kind of gives us a little idea that maybe your aorta will have time to grow before the risk for dissection comes into play. So it's like Dr. Estera said, it's an important discussion to have with your whole care team, with your surgeon, your cardiologist, genetics team, because there's a lot of factors that are into play when determining the surgical threshold and time to intervene.
Absolutely. And knowing, it's really important to know what size your aorta was at the time of dissection or at the time of surgical repair of an aneurysm, because that information becomes really important for family members if we don't haven't identified the gene in your family yet. And I want to mention, one of the things that's frustrating to me, and I'm sure everybody up here, is we do not have drugs yet that prevent dissections. We have drugs that slow the rate that the aorta grows, but nothing that blocks ultimately that dissection. And when the Leduc Foundation just funded an international consortium that I organized to actually go after identifying drugs that will do that. I think we're way behind other cardiovascular diseases in that matter, that we really do not have a whole list of medications we can give. And most importantly, we don't have drugs that block dissection, and it's just something we need. So we can say, yeah, your aorta is this big, we do want to repair it, but let's put you on this drug and make sure you're okay and you're ready to go to surgery and so on. That's what we need.
Great. And Bella, along the lines of taking each family into account individually, there have been a few questions from patients about getting access to care, access to genetic testing, and how we typically approach genetic testing in families. If a gene is identified, where do we go next in terms of testing family members? If a variant is identified and we're not certain if it's the cause, where do we go from there in terms of genetic testing? And to add on to that, not everyone is in the Houston Medical Center with access to all of this. So what advice do you have to patients and families to?
This is a very loaded question.
It is.
So
Gave it all to Bella.
Yeah, so the first place to start is, genetic testing is most valuable when the person who has the disease in question is the one that's seeking the evaluation and the one getting tested. So in this case, we're looking for somebody who has the diagnosis of aneurysm dissection, thoracic aortic aneurysm dissection, because they're the person that's most likely to carry the gene in the family. And so if we're testing a family member who, doesn't have aneurysm dissection, we don't know if they don't carry the gene that's in the family, if they're negative and maybe somebody else would have tested positive. We don't know if it's a gene that hasn't been discovered yet, so they're negative because they are affected, but they don't have one of the genes that's on the testing panel. Or we don't know if they even inherited the gene, right in the family. So this is why we recommend starting with somebody who does have it, because if their results are positive, then what we can do is we can do cascade family testing. So then we'll recommend, the genetics team will recommend testing for children, for siblings, well, children and parents usually first. And then if the parent comes back positive, then we move on to siblings because they have that 50% chance of inheriting it from the parent. If the parent has it, then their siblings get checked. So that's called the cascade genetic testing. And in the cases where it's negative, this means that there wasn't a gene identified. That's when we make the specific screening recommendations based on your family history, based on your own clinical picture. And then there's a type of result called variant of uncertain significance, or it's inconclusive genetic testing. You may have been told that your genetic testing was not conclusive. This is a tricky one that I think patients and providers do not like. But with this one, it's also on a case-by-case basis. So what it means is that you were found to carry a variant in this gene, whatever gene it is, but there's not enough data to say that it can cause dissection, not enough data to say that it's a benign change, because people carry genetic variants all the time that don't cause health problems. So this is the classification of those VUSs for short can always change. So they can always get pushed in either direction. And depending on the gene, depending on the data that's in the literature and what we've seen case by case basis, we can decide if we use it as part of your management and your treatment decision. So in those cases, we usually recommend genetic follow-up in 3 to 5 years to see if the classification changes, or even if your results were negative, genetic follow-up again to see if there's new genes available for testing, because we're constantly learning more. So there's more data being constantly put out there. We're learning more as the awareness for aortic dissection and genetics increases as well. And then the last thing that I wanted to touch on was access. So first of all, you all can reach out to us to that email address that Elena provided, the jrrp.research@uth.tmc.edu. I have it on my card outside, so that you all you can email us. But I usually, if you're in the state of Texas, we can see you in our clinic, either in person or via telemedicine. But if you're not in Texas, then what I usually do is I help people navigate these diagnoses. So I'll provide resources for looking for a genetics provider in your area. There's patient-initiated genetic testing, so you can work with the lab. They can go through your insurance, and then they can help order the testing for you. So it's a lot more accessible than people think, and insurance usually works pretty well to cover the cost too. So there's a lot of the labs offer, a patient assistance program. So there's not as many barriers as you think to access the genetic testing.
Remember that first poll question. It's cheaper than an echo.
Hey, and I'll just add on to it. Someone who's been in the program for 17 years, from the accessibility, today is the first day I've ever been in this building. So our entire family has been through this, and nobody in our family has been in this building, and today is the first day. So it's super accessible once you get in touch with Bella.
It's great. Thank you. So we've talked a bit about educating and increasing awareness. There have been a few comments about how we can increase awareness in emergency departments. How can we train providers better to recognize that aortic dissections can happen in people who are young? What are the key words people should be using when they go to the emergency department? And apps, medic alert bracelets, the cards. What can people do to just increase awareness and improve this?
Yeah, no, that's a great question. It's recognizing from a medical professional perspective really goes into the basics of like medical school. Be slightly off tangent, but how I had my awareness of the whole aortic health was actually John Ritter. He died September 11, 2003. Growing up, you always have your comfort TV, right? You can name whatever show. For me, when I was a young kid, it was Three's Company. When I was in high school and I was in college at the time, it was Scrubs. And it's going to sound cheesy, but Scrubs was like, oh, maybe I should do med school. That sounds fun. And I did. But that kind of stayed with me throughout like med school. And then, I graduated medical school in 2010, and that's when the Ritter rules came in. So yes, I did family medicine. I ended up doing sports medicine fellowship, doing inpatient medicine. But the one thing that always stuck with me was ascending aortic aneurysms. I don't know. I got that question right on every single test. But recognizing it, teaching it to our learners, our medical students, residents, fellows, fellow colleagues about recognition. And the key I always teach is like key words: chest pain, severe tearing. If you are a patient calling 911, everyone usually calls about chest pain. Typical when we think of heart attacks, it's like an elephant stamping on your chest. Aortic dissection is different. It's like a knife cutting through your heart. So if I hear sharp knife tearing, that's where my brain changes to say, hey, could this be an aortic dissection that I may be taking care of? So those are like those key words that both from a healthcare professional that I find for, and then for patient awareness, like say those words. That should trigger the mindset of a healthcare professional to go about that algorithm.
That's great. Thank you for that.
Hey, so and Ellen, you mentioned this, and I frankly forgot about it. If you don't know you have the gene or not, and there's the family history, we all wore medical bracelets, and it said a family history of aortic aneurysms. And so if you go down, like you go in cardiac arrest or you collapse, they don't immediately give you CPR. Hopefully they go give you an echogram or a CT scan before they go do CPR if they see the bracelet, if they read it on you. So we wore it. We actually had a cutting of I wore mine. I never took it off for 15 years probably, my medical bracelet. So we got to cut it off because I didn't have the gene. So if I go down, hopefully give me CPR and hopefully give me back. Someone here. But so the medical bracelet was something we did because we just didn't know. For those of us that didn't know we had the gene, it was just an unknown. So it was our kind of fail safe. Like hopefully someone looks at that. Us went down with collapsed or cardiac arrest.
Two quick points about not on the provider end, but on the family end. So Marfan Foundation website is great for a lot of things beyond Marfan syndrome. And one of the things that they have on there is a link to actually a company that will makes medical alert bracelets. So that's one thing to check out. The other thing too is there's a lot of apps out now. I think some of them are still free. Some of them might be a small subscription fee, but that kids even can carry their full medical history on them. So you port them into the app. So if they present in college to a hospital with which they're unfamiliar, they can have their history, including their aortopathy diagnosis and their risk of a dissection on that app. Yeah, an application. Yeah. I don't have any vested interest in any of them, but Backpack is one of them. Backpack. Yeah. And Backpack. I think there's others out there too. I don't have the Marfan Foundation website has links to a lot of these things. So just as especially for children, teenagers. It's one of the resources that we've pointed them to be, if they can't recite all their history, at least they can have it with them.
So keywords, if you have these symptoms, tearing, chest pain, and advocate for yourself in the emergency department. The medic alert bracelets, apps, the cards are available for everyone who's at risk, not just with Marfan syndrome. And I think the key takeaway is we will work on educating the med students, via scrubs or whatever other mechanism. But in the meantime, patients have to, we encourage everyone to advocate and help
I can add.
Please.
Sometimes you have to be forceful, especially if you're young, because they can let you sit in the emergency room for hours. And I personally know someone that went through that. So if you have to go to the front desk and pound on it and say, I need to be seen now, do it. No one will be better advocate for yourself than you.
That's right. Dr. Estrella.
I'd just like to add that we as a group are very biased because we all live this every day. We're aware of it. The reality is 9 out of 10 patients who come into the emergency room presenting with dissection had no clue of what was going on, no family history. We see it almost every week, these patients who come in emergently and who are dying. And fortunately, at least around Houston, people are aware of this because it goes back to the Bakey and Cooley and a lot of the work that, Crawford and all these folks did, 50 years ago, making people aware of the surgical, treatments of dissection. But I think the work that the John Ritter Foundation is doing with regards to hitting the ERs and increasing awareness, because it's not uncommon for me, even today, to hear the story of the patient coming back 2 or 3 times to different ERs until someone in that ER realized that this could be dissection. So to attack this, in my mind, would be to go in that direction and hit all the emergency rooms and get all the ER physicians and the first line treatment folks to be really aware of this and keep this in mind. We understand that 25 out of 26 times it's going to be acute MI, but we don't want to lose that 1 out of 25. That's where, a lot of the work that you guys are doing, the JFR is doing regarding, educating the ER physicians and making people aware of this is going to be very important in having an impact in this, in my mind.
Tony, are you going to come work for us? That'd be great. You're excellent. We'd love for you to just come work for us. Just.
Pretty do, don't I?
You do. So for those of you that are for free, thank you. Yes.
Actually,
You donate. Yeah, you paid me last year. That's right. This is Meredith for those of you who are on the video. I do want to just remind you guys, we are investing in a grant with the American College of Emergency Physicians. After long discussions with them, they told us that they really needed a risk stratification score. This is something that we have shied away from in the past because we just didn't have the research and the information to know what that risk stratification score would look like. So this is a 2-year grant that we are looking at tens of thousands of electronic medical records to come up with this risk stratification score. And we are extremely hopeful that we will have something out in the next 2 to 3 years that will help people with acute chest pain. They get a Ritter score and a Hart score, but Diana can speak more to this.
No, I just want to say that they wanted to do this study and approached the John Ritter Foundation for funding because they know their numbers. They know that 1 out of every 4 dissections is missed and that person is sent home to die. And no ER physician wants to send somebody home and miss a diagnosis of aortic dissection. That's not what they want to do, and they will never forget that the rest of their lives. So they wanted better tools.
So lots. Yes. Great. That's good advice. And I don't know if that translated to everyone, if everyone could hear that, but the advice was urgent care, not the same as emergency department. So seek care at an emergency department to really get a good evaluation and rule out dissection, because that's important. But if you're being taken in an ambulance, you don't get that choice. So they're going to take you to a hospital for that evaluation. So two more questions, and then I think we'll wrap up. And like I said, we can address any of the specific questions via email. So Dr. Prakash and Dr. Estrella, once you have surgery to repair your aorta and you have that graft put in, either after a dissection or for an aneurysm before the aorta dissects, what's the lifespan of those grafts and what does that follow-up look like after?
I can talk to the follow-up because I typically take care of patients after surgery. And the important thing I emphasize to people who have had any type of surgery, whether it's for a dissection or an elective repair of an aneurysm, is that it's not the end of your story. Your story continues for a lifetime, and aortic care or aortic health is a lifetime endeavor that requires follow-up. So we know that some people still have the risk to develop aneurysms or dissections of the rest of the aorta that has not been repaired after their operation. It may not be a high percentage, but again, we don't want to miss those cases, and it is totally preventable, as we've talked about many times here. That requires screening that might be different than the screening you had when your aneurysm was first diagnosed, because it's in a different part of the aorta, like we talked about before. So you may end up needing a different kind of screening test and different intervals. It will change after your surgery. So again, it's important to visit with your care team and reset your expectations after the surgery, get a new schedule and understand it. Make sure you have your questions answered about how often you need to come back and what kind of tests you need.
Regarding the graft, Dacron graft tube, artificial, was developed by, honestly, Dr. DeBakey here in the 1950s. Remember, before that, the treatment of aneurysms was either ligation or wrapping with cellophane, which obviously didn't work. Albert Einstein had his AAA wrapped. If you didn't know that, it lasted about 6 or 7 years, and then he died of rupture. He was trying to come to Houston, is what I had heard, but didn't like to fly. And so he was waiting for a train, didn't work out, died in Yale, in Connecticut. Anyway, and then before the Dacron graft was developed, Dr. DeBakey and others were taking human aortas, infrarenal aortas, would go to the morgue and just harvest, we call them homografts now, and use those as the actual substitute for the aortic, to treat the aortic aneurysm. Now the Dacron graft, where DeBakey actually supposedly used his wife's sewing machine, went to Foley's and put the polyester and made it a tube graft. And actually that's where this all came about. And for that reason, I always say to my patients that I expect this to last you the rest of your life. So that Dacron graft is very, very, very durable. And granted, the areas around it, can still dilate, but that segment, should last you the rest of your life, unless it gets infected, which is 0.1-2%, very low risk. So I feel very good about that. Endovascular stent grafts, if you think about it, the minimally invasive approach, which comes up through the groin, deploy a stent, is not sutured in. The fabric is good, Dacron or polyester, but because the ends are not sutured in, there is a potential that can migrate or leak. You hear leaks. So that's why those stent grafts, those less invasive procedures, which are very good, just have to be monitored much more closely. I feel very comfortable about a graft being very stable for the life of the patient. But as Dr. Prakash said, the rest of the aorta has to be followed. And with stent grafts, you just have to follow those more closely. And fortunately, if they do develop or spring a leak, you can oftentimes treat that with another stent graft. And rarely do we ever have to go back in and actually take that stent graft out and replace it with a actual Dacron graft. So my comments on grafts.
Go ahead,
I
Bella.
just want to
Yeah.
ask a question that you
Yeah,
might
yeah.
have, but for both of you, maybe for Dr. Estrella, can you explain why, say somebody had their aortic root or ascending replaced, why their aorta is considered diseased after the surgery, even if they have a graft? So why would the aorta be considered diseased aorta? Why would you keep monitoring?
Yeah, I don't think the actual part that you actually replace is necessarily quote unquote diseased. I'm fine with that. But it's the other areas you just have to follow, as Dr. Prakash said, because there is a chance that other locations can develop aneurysms. So that's sort of what I think about that area, that area that you've replaced with an open repair and Dacron graft. I feel that's going to be very, very durable long term.
Yep. So you get your aorta repaired, but you can't give up on follow-up. and you can't give up on your blood pressure medication. And because there are different types of aortic repairs, endovascular, the Dacron graft, we had a few comments about the Paris procedure, which I will not get into, but all of these techniques are evolving. So the follow-up will change, and the recommendations may differ depending on the extent of dissection, what type of repair you had, and your family history. Is that right?
Let me comment real quick on pairs. I saw the chat.
Okay.
I didn't want to get into it. Pairs is wrapping, is developed in Europe. They're taking Marfan's patients and actually wrapping the aorta with a personalized, customized sort of graft. It seems to be okay in terms of the follow-up and outcomes right now. It's really still at midterm, but the reality is wrapping any better than actually replacing it? I'm not certain. I think the jury's still out. I'm still waiting to see how this plays out. PEARS. But the other issue is they're wrapping it in small aortas. So would those of aortas had problems anyway? I'm not certain. So just officially, my jury's still out in my mind about wrapping. So that's why it's not approved. It's not going to be approved in the U.S. for a little while. If it is in the next decade, until some of these results are come out, longer term results.
Thank you for that. Yeah. Could you repeat that?
Yeah, the question was, once you have surgery, do you follow up with the cardiologist and or the surgeon? You know, a lot of times most surgeons will release the patient back to the cardiologist, and I'm fine with that. But I honestly offer to see the patients as well, because you have this relationship, and a lot of patients in this room, you know, I don't mind seeing them, every year. It's not a big deal for me. And I enjoy seeing them because I like to catch up, with what's going on. So I don't have any issue with, and I enjoy seeing patients and follow up, but it depends on the surgeon. That's my thoughts. Yeah. That's a great question. That question comes up a lot. So let's say you have a 4.5 centimeter aneurysm, and the threshold's 5 to 5.5, and you got it, and you're relatively young, and patients always ask, if I know that it's not going to shrink, it's only going to grow, why don't we just do the operation? Well, I'm fine with that. I like operating. That's fine. But I personally want to make sure that the patient understands the risk, because although we have great results, they're very good results, there is still that 1% chance that something bad can happen. Infection, stroke is devastating to have a stroke, and it's 1%, no matter what anyone tells you, and that can happen. And so just as long as the patient's accepting of that fact, that I'm willing to take those risks, I want to get this out of the way, let's get it done, then I'm fine with that. I have no issue with that operating. But I set this up, I don't make that decision with the patient immediately. I let them think about it, and if they come back after, a month or 2-3 months and they want to have surgery, I'm not going to deny that. And it hasn't really been an issue with insurance, because just as long as I document, things and write it in there, what are the indications, we can do it, because we know what, in general, the natural history. Now, on the flip side, I have some patients I've been following for 15 years, and they sit right at 5, and nothing changes, and they're fine with it. But I think about the spectrum of different kinds of patients. I got that cattle rancher who's 72 and says, "Doc, when it's my time, I'm fine. I don't want surgery. Just follow me. And if it happens, I've lived a good life." You got that spectrum. And then you got the other person on the other side, on the other end of the spectrum, who's just so fearful, cannot function, cannot sleep. It just absorbs them. That's the person towards that spectrum that I will, have no issue operating with. They just have to accept that 1 or 2% risk of something bad happening. And if they do that, I'm fine with that.
I just want to make one quick follow-up comment that those low complication rates are with cardiac surgeons like Tony that do this operation day in and day out. So if you're going to get your aorta repaired at 4.5 or even 5, I would strongly recommend going someplace where there's an experienced aortic surgeons. Because if you go to a community hospital where somebody doesn't do that many cases per year, those complication rates go way up.
I'll take this
Can
one.
you summarize? Can you summarize the question again for the?
The question is, the daughter and the mother, who's 85, has a 5.3 centimeter aneurysm. Where's the location, by the way? Did they say? Thoracic. So in the front, or they didn't tell you where, ascending or descending? Anyway, aneurysm, and she worries so that anytime she has a little discomfort, is it the aneurysm? And so the question really is, what is the point where you might consider doing something, or how do you deal with this kind of patient? And the daughter says, and the doctor says, don't worry about it, but it's hard not to worry about it because you got this thing in there. Now, but having said that, what I would say, I mean, granted, 85, there's physiological age, there's chronological age. If this thing had been stable, and I was seeing you, and I'd seen maybe 4, 5, 6, 7 CAT scans and images that all look pretty stable and feel very comfortable that it's stable, then I would say probably the same thing. Just live your life, watch it. I'm not certain about location. Sometimes if it was bigger and it's in a location where we can do a less invasive procedure like a stent graft, then I might push in that direction. Maybe not at 5.3, but maybe something bigger than that. But again, the ascending aorta, we don't have really good endovascular treatments for the ascending aorta yet. I mean, a lot of folks working on it, but not yet. But it's hard, so. Okay. Deceased of what? She said, so the same patient had valve surgery years ago. How long ago? 20 years ago, and had 5 siblings, and 3 are deceased. 1 had a rupture. And that's what you're wondering about. So. It's true. So, yeah. So what do we do? Yeah, I agree. This is a very difficult question. That's why I'm going to ask Dr. Prakash to answer it.
Nice move.
I think the most important thing is for us to know as Dr. Estrella said, how the aorta has changed over time. So one of the things that I would do if I was, if I were looking at it is, again, look at those, the scans you've had of your aorta. Is it changing? Is it not changing? And that, and with the location, that tells us a lot about how, how concerned we need to be. Then we would sit down together and get the information so that, as we talked about, having that information helps us to decide, but it also can help reassure you that we're basing this on solid evidence and you can see what we're doing. And then we, as a care team, we go forward. That's how we approach this usually. Yes, it sounds like there are a lot of factors here. So we can continue this conversation on a one-on-one basis, maybe.
And I wanted to also add, if I may, if anxiety is also impairing your quality of life, if anxiety is also a factor that impairs your quality of life, that's something else you can address with a mental health professional, because it's not necessarily about taking medication. You can learn to do diaphragmatic breathing, progressive muscle relaxation, guided visualization, and meditation. And all of these things will help you better manage that reaction of fear that you frequently experience.
And this is a good note to kind of end on, because I think the takeaway is that it takes a team. There isn't one simple algorithm to make any of these decisions. Having a family history and experiencing a family member passing away from a dissection can impact, how you feel about it, the growth, some of, the science, the genes, experienced providers, all of these things, play a role in how these decisions are made. So I wish it was easier, but it's a process, and it's different for everyone, and it takes all of you and the speakers here to help get through all of this and make these decisions. Dr. Stur, what were you? I didn't see. Oh, I see one. Okay. So we don't have a microphone. Is there a way that starts? Okay. You're in good hands with him. Any other questions from the audience?
Thank you for that. I'll repeat what you said briefly so that our online audience can hear. You told us that you had a dissection, that you survived a dissection about 5 years ago, and you were recently hospitalized with very high blood pressure, over 200 millimeters systolic, and you're concerned that you could develop another aneurysm or dissection. I'd like to refer back to what Dr. Estrella and I were talking about. After the first repair, it is a lifelong disease. So we consider all patients who survived a dissection to be at risk for future aneurysms or dissections. Everyone should get checked on a regular basis. And of course, controlling blood pressure, as you said, is extremely important in preventing or reducing your future risk for a dissection. Sounds like that's an ongoing struggle for you, and that's not unusual because blood pressure does also change significantly after dissection. Dr. Sturr and I see this frequently, that patients who are on many medicines sometimes discontinue them because their blood pressure drops, but it's not necessarily predictable. And blood pressure can increase after a dissection depending on how it affects blood flow. So it's not unusual. Your situation is unfortunately all too common. When there is a change in blood pressure after dissection and increased risk, it requires, again, a team approach with your surgeon, with your cardiologist, and adjustment of your medications is what will be needed over probably a period of months.
I just want to add, thank you, Christine. You highlight a really big issue with regards to aortic health, medical health in general. And we had our speaker, Isabel, talk about mental health. And, we do a great job with the surgery and medical issues here, but we really don't do a good job with the mental health issues that occur after, these devastating, situations. And this is just a call out to all of us that we probably should figure out a better way of how we address this moving forward. And I know it's coming to the forefront in a lot of aspects, just in general, mental health, but we could probably do a better job. And I'm not the expert to tell you how to do this, but just as this is more of a rhetorical question, just, comment, we just need to do a better job at that. So, because I understand, your concern, and all the patients that we have with dissection, have this concern, can this happen again? And frankly, yes, it can, unfortunately. The segment of the aorta that your doctor saved your life was that usually the front part. They saved your life. They did a great job. You're here now. But the remainder of your aorta, once it dissects, has now been altered. And although, it's not 100%, but there is a significant percentage of that remainder aorta being at risk for something else happening. That's why we want to use the information we get from Diana to address this before it dissects. Because if you can fix this before it dissects, then you have a much better chance of having a relatively normal life, because the rest of the aorta is only, I always quote, a little bit higher than normal risk, but it's not the same as when it dissects. Because once it dissects, now it affects the entire natural history of your aorta. That's why we're so attuned to fixing these things before it becomes a problem. Because once it dissects, then your chances go down of making it to the hospital, your chances go down of making it through surgery, and your chances go down or go up with regards to needing something later on. So I don't mean to scare you, but you're in control now because you know it, you own it, as I said earlier, and you just got to be followed. Yeah, in essence. Remember, dissection is when the wall splits, and I always take some paper. So no, remember, aneurysm is when it dilates, and now the wall's at risk for dissection. Dissection is when the wall splits. Remember, it's layers, and it splits on the inside, and then it creates a true and a false lumen, and there's a flap. That flap comes all the way down. We talk about tearing because that's usually what happens, and it feels like a tearing pain, you know, when that flap propagates all the way down the aorta. And that's what I think about the section.
Great. I think that's it. And Christine, I think it was, I think it's fair to say that if you don't have a condition like Marfan syndrome or Loeys-Dietz, and there's no family history of aneurysms in other arteries like the brain, the likelihood that something is going to happen in another artery completely unrelated to the aorta is still pretty low, right? So I think that often patients ask, well, what's the likelihood that something's going to happen to another artery? And assuming all of those things, it's still a pretty low risk. So did I miss anyone else? One. Walk until you drop. That's the takeaway to end this. Thank you. Dr. Prakash, did you want to?
Yeah, so a few notes. We have the raffle drawing for those of you who participated in the room. So let's end the virtual segment. Before we do that, any other notes that we need to, or reminders? Yes, there are booths about research and many of the topics we were discussing with information, and also you can meet the speakers outside, so please stay and mingle if you can.